Okay. Okay, good morning everyone. I'm Kevin Orford, Chair of NHS Devon. Welcome to the 2025 meeting of the Board of NHS Devon, the Devon Integrated Care Board. This is our meeting held in public, which is streaming live to our YouTube channel today. We have apologies today from Kate Shields, Chief Executive of Cornwall and Isles of Scilly, ICB. Apologies from Alison Williams, System Recovery Director for NHS England, and apologies from Donna Manson, Devon County Council Chief Executive. I'd like to welcome to their first board meeting Councillor Mary Aspinall, Chair of the Plymouth Health and Wellbeing Board, who's been appointed as the Chair of the One Devon Integrated Care Partnership. Also, at his first board meeting, Phil Munte, Chief Executive Officer of Devon Partnership Foundation Trust, who's been appointed as our partner member for mental health services. We welcome also Libby Ryan Davis, the Transformation Director at NHS Devon. I think, Libby, this is your first board meeting as well. We welcome also Lopa Patel, who will be joining NHS Devon as a non-executive member from next week, but is here today as a member of the public. Welcome, Lopa. We're expecting to join us Tracy Lee, Chief of Staff of Cornwall and Isles of Scilly ICB, who will be deputising for Kate Shields. Want to welcome those NHS Devon staff who are joining the board in a new role. That's Kirsty Denwood, our Interim Chief Finance Officer, and John Finn, Acting Chief Operating Officer. Online today we have Graham Clark, non-executive member, and also Sophie Pallett, Deputy Director Intensive Support for NHS England, who is attending on behalf of Alison Williams. We welcome also Mark Cook, the Managing Director of NHS England's South West Region, to the meeting. Welcome, Mark. We welcome also those members of the public who are viewing the meeting online today, and I'd like to remind everyone that this is a meeting in public, but not a public meeting. There is a board meeting in private session which follows the public session. In the private session today we'll be discussing items commercial in confidence relating to community care provision. So before we start, can I confirm, Philippa, that the meeting is quorate?
Yes, I can confirm that.
Thanks very much. So if we can move now to the declarations of interest, which are listed at item 1.2 on the agenda and in the pack. Is there anything which anyone wants to add to the declarations, or anything which we need to draw to the attention of the board relating to today's agenda? Okay, we note the declarations of interest. Should Tracy Lee join us later? Tracy's made a nil declaration for the Register of Interests, which we received that after we'd sent the pack out. So just to let the meeting know, there's a nil declaration from Tracy. Let's move to the minutes of the meeting of the 28th of November 2024. I'll not go through these page by page, but can I just ask, are there any points of accuracy which anyone would like to highlight? Okay, if not, then the board approves the minutes of the meeting of the 28th of November 2024. If we move on to the action register, just bear with me a moment, let me just bring it up on my thing. We've got a number of actions which are recommended for closure. Can I just ask if everyone is content with those recommendations for closure, or are there any questions anybody has about those? Okay. And then there is a number of actions in progress. Again, can I ask if there are any questions on those actions in progress, or any further updates that anyone would like which aren't included in the paper? Okay, in that case, let's agree the closure of actions 68, 71, ICB 24, 37B, 39, 59, 360, 79, 80, 83A, and 83B, 86 and 91. And let's note the updates in respect of actions 69, ICB 24.9, 38 and 91. Can I just check with Philippa whether we are taking the question from the member of the public even though they're not here, or are we deferring that now? Sorry, I meant to ask that question.
Sorry, Chair. I would like to give a response on behalf of the two individuals that brought the question. Happy to do it whenever you feel is the most appropriate.
Shall we just do that now, Peter, and then we know that we've covered that.
Very sorry to interrupt. On the Teams chat, it seems that the people dialing in on the live stream can't hear. So
Okay,
just,
so
before you
can
take the public, I just thought it was important for you to be aware that.
Yeah. Okay, Josh, can you see what's happening with the live stream, and apparently people can't hear it. Okay, we'll leave it with you, Josh, and then we'll get an update on that. Okay, perhaps it's a localised issue then, but Peter, over to you for an update on the question from a member of the public.
Thanks, Chair. So I met early this morning with Drs Whitehead and Jetsam, who had posed a question around the length of time that it had taken for the ICB to review its fees for doctors who are undertaking work under Section 12 of the Mental Health Act. I explained to them that we have completed that work over the last couple of months, and we've taken it through our governance process with a view to outlining our position on the fee, and with an intention of starting the new fee structure from the 1st of April. They recognise and are grateful for that work being completed, but would want the board to understand that the fee, because it will not be in line with recommendations from the British Medical Association, although it's been benchmarked with our local ICSs in the region, will pose a risk that doctors will choose not to undertake this work, which will pose a risk to those members of our population who need assessment under the Mental Health Act.
Thanks very much for that, Peter, and we'll make sure that we record that fully in the minutes of the meeting. Thank you. Now let's move to our regular people and communities item, which serves to highlight to the board some experiences of health and social care in Devon. We've got a short film today which focuses on a patient's experience of the Plymouth virtual ward after she was admitted to it following discharge from Derriford Hospital in November. This is linked in the video to a discussion around the management of winter across Devon this year. Now, before we see that film, I'd just like to bring in Sam Wadham-Sharp, who has been the winter director for Devon this year. I just asked Sam to provide us with an overview of how the system coped with winter so far, and also to highlight some of the initiatives that have been in place, as well as virtual wards, to help us to manage that. So over to you, Sam, and then we'll play the video.
Thank you, Chair. So I think it's fair to say it has been a challenging winter to date, and we're not out of winter just yet. I did submit a paper to Finance Performance Committee earlier in January, just giving some overviews around some of the data that we're looking at and some of the interventions that we put in place, and we'll be sending a further iteration of that paper in March. As part of winter, I assumed the role of winter director in November 24. In terms of describing some of the challenges that we've seen so far, all types of attendances in our emergency departments have increased by 10.12% so far this year. Ambulance growth against total attendances has increased by 20.5% so far this year, which tells you about the levels of both demand and acuity that we are seeing within our emergency departments. And when we couple this with the challenges and levels of demand that we're seeing in both primary care and mental health services, it tells you about the challenging position that we've been working within through winter so far. In terms of regionally, flu presentation saw an earlier spike within flu A than both the national expectations and the national positions. And regionally, we've also seen a higher level of admissions than both the national expectations and the national positions within the southwest. However, we've been significantly under the projections for flu B, so we've been able to manage that better that way. We've also anecdotally seen better management of infection and prevention issues within each of our acutes, with fewer beds closed this year and less impact that we've seen within flow, and also the impact on discharge, particularly into care homes and nursing homes. So that has been an improvement this year. In terms of some of the success criteria we set ourselves for winter, we set one which was to declare fewer system critical incidents than we did within the winter of 23-24, and within that winter we declared 3 system critical incidents. So far this year we've declared 1, and that was a system critical incident declared on Tuesday the 7th of January based on all 3 of our acute providers declaring an internal critical incident, and SWAST reaching their highest level of escalation and sustaining that level of escalation for over 7 days. I think it's important to note that many systems within the South West region were in the same place and also declared system critical incident either prior to or after Devon doing the same. This allowed us to test our surge and escalation protocol, which we rewrote within December, and we were able to de-escalate that system critical incident just over 24 hours later at 3:30 on the 8th of January. I think this highlights our ability that we have seen through winter to recover quicker from periods of surge than we have done in previous years. And it is showing the greater grip and control that I believe that we now have within the system, again, from previous years. And we should note that performance measures for acute urgent emergency care are better than they were in November and December 23, except category 2 response time. So I think that's a good test of our grip and control. In terms of the video that we're about to watch, it will describe the experience of one of our patients who was treated via our virtual ward in the Western locality. So virtual wards are one of our 6 programmes of work from the Out of Hospital programme, and it enables patients to be treated in an alternative location than within one of our acute beds, and is important for us in terms of maintaining flow. It should be noted that virtual wards are not a programme work that we put in specifically for winter, and they have been running for over 2 years within Devon now, with sort of various different service levels across the system, but they are a significant part of our bed mitigation for winter, alongside urgent treatment centres and same-day emergency care and other measures that we're looking at. So I'm happy for us to show the video, and then we can take any further questions around how we're managing winter afterwards, Chair.
Thanks for that introduction. Sam, if we could play the video. Josh, thank you.
Winter is always a challenging period within the NHS, and through combination of pressures, through increased prevalence of flu and other viruses circulating, it's always a very, very busy time of year. Every year we approach that by working collaboratively with system partners in order to find solutions that ensure that as many individuals as possible are supported in the community, so keeping people away from the front door of the hospital, and then for those individuals who do find themselves in hospital, finding ways to support them to get out of hospital and back home as quickly as possible. Everybody knows there's no bed like your own bed, and so absolutely our priority is ensuring that we can help as many people to be at home and stay at home wherever that's possible. So we use initiatives around enhancing our discharge arrangements. We do jointly with local authorities and community service providers to help people, work with the community and voluntary sector to make sure that we've got support arrangements to help people within the community access the support that they need at the time they need it. And then increasingly this year using initiatives such as the virtual ward offer that looks to ensure that individuals who have a continued need for care, but that care can be delivered in a different way using virtual check-ins with support and supervision, but access to the appropriate care that they need, can have that care at home, whether that's prior to a hospital admission or as part of a discharge arrangement.
It makes things easier to cope. As far as I'm concerned, I'm home. I've been in hospital several times in the last few weeks, unfortunately, but luckily now I'm coming to the end of treatment, but also I'm able to be treated at home, which is a big relief when it's gone over so many weeks. So it takes the pressure off for home for me. To come home after you've been in hospital for a while, first of all, it feels very strange because you've been relying on somebody to do everything for you, telling you whether you can go to the toilet or to whether you can have a cup of tea and how long you've got to wait for that anyway. And so, first of all, when you come home, you think, oh, who's going to do that for me now? And then you realise that's what your husband's for. But of course, it's got to work. It's got to work both ways, and it's lovely to come in your own front door and be able to think, I can relax because it's us.
So patients are absolutely loving being able to go home, quite understandably. So they're loving being able to have their treatments at home, particularly with the IV patients where maybe they're on really long courses up to 6 weeks. That's a long time to spend in hospital if actually, generally any otherwise, you're feeling okay. Patients are feeling that actually daily phone calls are reassuring enough. They're actually happy for that input. They feel like that's actually enough for them.
What I've learned so far is that I'm managing quite easily with the electronic side of it. I'm supported well. The staff come and help me if I need it at home, and also if there's anybody needing to give me any advice, I can phone up and I can get it straight away. There's always somebody who seems to be there for you. It's good that the nurses came in as they did the other day, and it's going to happen again this week because I believe I've got to have blood taken again this week. Well, I've got a son and a daughter, and they both do as much as they can do. They both work full time. They come when they can, and they know that they're not having to wait until visiting hours, and they're not going to have to try and get up to Derriford and try and find a parking space. So if they've got 10 minutes that they can pop in and see mum, and hopefully dad as well, then that is going to be 10 minutes with us as opposed to 10 minutes up the road and then another 10 minutes to find this and that. So hopefully that means that they feel less pressure and are able to come and we start become a family again.
So thanks very much for that. Thanks very much to the team who produced the video for us. I'd like to invite some perspectives from the system, but I'll go to Judy first, and then I'll bring in Sam, and then Frank.
Sorry, I just wanted to say thank you very much for that, and it's really good to see the virtual ward programme taking off, because I knew it was a little tricky at first getting people used to it. We've actually been running hospital at home in the NHS for over 30 years, so it's not such a new concept, so I'm really pleased to see it. I think it's absolutely crucial for our 3 shifts as well, services like this, but we do need to make sure that they are reliable and sustainable, because if they are flaky and suddenly somebody, we can't get staff for them or things, people will stop using them. So there's something about thinking about ensuring the funding for these kind of things and then ensuring the use of them. It was lovely case study. She brought out so many of the benefits.
Thank you, Judy. Sam.
So it's great to see the work on virtual wards, particularly that's taking place in Derriford this winter, because it feels like they've really made a step change, and that's definitely helped. And it's back to Sam's point about it's early days, but it does feel like we've managed this winter better than last, and I think virtual wards across the whole of Devon have been part of that. As Judy says, our challenge now is to mainstream them, isn't it? And historically, what we've done is very much focused on the medicine specialties, and I think there's more we can do on the surgical specialties to really drive it forward. And then the other bit is, at the moment, most of our virtual wards are stepped down, and I think there's more of a conversation we can have with primary care about can we create more of a step-up opportunity. So there's some way to go, and I guess, hopefully we can pick that up in the lessons learned work that Sam's talking about doing for winter, because there's some other things we really need to get under the skin of this winter in terms of why have we seen some of those peaks in flu? Is that to do with lower levels of vaccination rates? And also we know we've got some real demand hotspots, particularly in Barnstable and Plymouth, and I don't think we know yet enough about what's driving some of that. So, but it's, really impressed.
Thank you, Sam. Frank?
As a GP, I absolutely agree with the comments that have been made by Judy and Sam. One thing I would say, though, is this is a service and we're delivering the service to people. Not everyone has a husband, wife or carer at home, and it's not suitable for absolutely everybody. And some of the home conditions that I go in and see, you really wouldn't want to be sick in them. So it's a great system response and it really will help, but we still have to think about the individual and whether it's suitable.
Thank you, Frank. Martin?
Thanks, Kevin. Just to decode or to put in my report, actually, from the Finance Committee, because, of course, we reviewed the winter plan there, and this was one aspect of it. And I think it's fair to say we were quite impressed at the level of system working that seemed to be coherent in managing some of the pressures. Obviously, we had spikes and issues over the winter and continue to have them, but it was nice to see that some of these issues tended to be resolved perhaps faster than they had been in previous years, which was a sign of progress. I think the committee were quite supportive and wanted to bring back to the board that actually, when we focused a lot of solutions on, ED, urgent care, hospital, we felt we should actually push these solutions quite significantly as a board, because all the other things we've talked about, hear, see and treat. We talked about step up, I think, Sam, a great example. If we can build that in, enhanced discharge, actually are the things we need to put, across the whole piece to make sure we're not just focusing on that one area of pressure, but having to solve the issues that we see by partnership working across the piece. So a good report came to the Finance Committee and we were assured on the progress to date, really.
Thank you, Martin. I'll come to Tandy and then perhaps I'll come to Sam, so if there's any summing up points that you want to make around it, Sam. Tandy.
Yeah, I'm just agreeing with everybody about the progress being made here. But I think it still feels piloty in terms of the phase that we're at. And I'm thinking that if this is going to be part of how we deliver services for the future, do we have an idea of what scale would be required and what difference that would make, assuming this is where we're heading? Should we be having a figure in our head that at some point we need to have visual wards that can cater for, 1,000 patients, and what difference would it make on what?
Thanks, Tandy. And I'll bring Phil in now as well, actually. Thanks, Phil.
Thank you, and it's fantastic to hear the human story on the end of some of the things that we're trying to do better. And I just wanted to add as well to it that in mental health we have what we call crisis and home treatment teams, who, whilst we wouldn't call them a virtual ward, have a really similar approach in terms of supporting people in their home when they're in a mental illness crisis to avoid them needing to be admitted to a hospital. So I think it's really important that the board has sight of it's also in the mental health space that this is working.
Yeah, thanks. And John, I think, as well.
Just to recover, just to reply to the question, for UHP, we had an ambition of 84 beds this year. Now, we're not quite there, but with some recruitment in terms of January, we should get there in the coming weeks. But I think in terms of the ambition going forward, and in terms of the big part of Plymouth's One plan, is just as Sam has said, actually the ambitions around emission avoidance is where the increased capacity is required. So in our plans for this year, we'll keep where we are in terms of step down, but the real ambition, the transformation needs to be in the emission avoidance sector.
Thanks, John. Any final reflections, Sam?
Yeah, just a couple. I think the point about flu and vaccination, Sam, is a really important one, and I think it comes back to our overall evaluation for winter around, do we try and follow regional and national trends, or do we do what we think makes the biggest impact for Devon and really think about the population that we have? So we have followed the regional numbers and trends for both vaccinations in staff and in the public, but we've seen a larger spike. And therefore, do we really need to double down on that next year and get back to the levels of vaccination that we saw previously? I think in terms of the demand and also our out-of-hospital programmes as a system, so the 6 programmes, when you look at them individually, they are all delivering what we thought they would deliver to a certain level. But when we then think around the numbers that we wanted to achieve in terms of reductions in attendances, admissions, conveyances and supported early discharge, we have not made the impact in those numbers that we wanted to. What we can't work out at the moment is, would these numbers have been worse without these programmes? But we've got to get into that evaluation. And the one thing that we do struggle to answer in Devon at the moment is with the increased levels of demand that we do see, particularly in North Devon and in West Devon, where is it coming from, and what do we need to wrap around those patients to keep them at home? So we are really pushing to understand that, and we're running an event in the west of Devon over the next month to really try and understand, both from primary care perspective, care home perspective, and those patients that we cannot see that are within the call stack for 999, who they are, and really then try and work out what is that out of hospital programme that we need to aim at these people to keep them in the right place and away from our hospital. So whilst I think we have made improvements this year, what I want to say is there's a huge amount of evaluation and learning to take, and still a lot of work for us to do to get ourselves back to where we want to be.
Thank you, Sam, and thanks for everyone's contributions to that. And I think the thing we take away from that is the improvements in the management of winter this year, but also the evaluation and learning that we'll take from that in terms of preparing for next winter as well. Can I thank Chris Morley for his reflections in the video on the Plymouth system response to winter priorities, but also to Sue Miller for sharing her experiences of the virtual ward, and to nurse manager Sandra Lacey from UHP for her contributions to the video as well. And can I just say thanks to everyone in the ICB team, but also across the whole of the health and social care in Devon for the tremendous effort that has been put into responding to winter this year. Thank you to everybody. Let's just welcome Tracy Lee, who's joined the meeting. Welcome, Tracy. And let's now move on to the leadership reports, and we'll take the chair's report first. So I'll take most of the report as read, but there are a couple of issues to highlight to the board which relate to recommendations for the board today. First of all, though, I just want to say that I do feel really privileged to have been appointed substantively to the chair role at the ICB, and I do just want to thank board colleagues, system partners and the ICB teams for all the support that I've had over the last 8 months during my period in the role of acting chair. And I look forward to continuing to work with everyone. The report from me this month also flags up some further changes to the board in that following a competitive recruitment process last November and December, we've appointed 3 new non-executive members who will take up post in February. These are Salma Ali, Kay Bentley and Lopa Patel. Each of these bring extensive experience and capability to the membership of the ICB board, and we really look forward to working with them. Now, these appointments also provide an opportunity to review the membership of board subcommittees, and there is a recommendation in my paper that the board delegates to the ICB chair the authority to make appointments to subcommittees during February and March before the next board meeting, and that will enable us to set the memberships now without delaying us to March. I've already referenced in the meeting the appointment of Councillor Mary Aspinall as ICP Chair. Mary's attendance at ICB board meetings will bring further experience and capability to the team here, and we look forward to forging really close working between the ICB board and the ICP. We're currently working with Mary and ICP members to form proposals for the ICP work over the next year, and we're being supported in that by NHS England's South West Regional team. They're working with us on good practice that they're observing in some other ICPs across the region, across the country, which we can learn from. I'm also reporting on the first meeting of our Population Health Improvement Subcommittee, which took place on the 9th of January. There's a proposal to amend the terms of reference of this subcommittee and also of the Quality and Patient Experience Committee in relation to the provision of assurance in respect of patient and public engagement. So the detail of that is in my report. Can I ask if there are any questions or observations on that before I move to the recommendations? Judy.
So first of all, I think we ought as a board to say congratulations to you. I think it's great for Devon that you're going to be the chair of the board, so wish you well. I wanted to just say how pleased I was that the Integrated Care Partnership Board is going to be meeting again, and thank you, Mary. It's such an important board for us because it really gives us the opportunity to connect with other opinions and views around the system. And I would remind everyone that we were one of the first to get our Integrated Care Partnership working and actually got national recognition for it. So it's been a great source of support in forward planning in the past. So thank you, Mary.
Thanks, Judy. Are there any other questions for me? In that case, can we note the contents of the report? Do we have board agreement to delegate to myself the authority to appoint the new non-executive members to board assurance committees for the remainder of this financial year? Thank you. And can we approve the proposed drafting amendments to the terms of reference for the Population Health Improvement Committee and the Quality and Patient Experience Committee? Thank you. So at that point, we'll move on to the Chief Executive's report. Thank you, Steve.
Thank you, Chair. Just building on what the Chair said, I'm about 2 weeks off my first year anniversary now of joining the ICB, and it does feel, for many of the reasons that Kevin set out, it feels like we are now turning a page on a new chapter for this organisation and for the system. So I firstly just wanted to personally say how delighted I am that Kevin's been appointed as chair. We work really strongly together and we've got a really clear vision together about what we want to achieve, and I think that will really help the organisation and the system to move forward. Also delighted with the announcement of our new independent members joining us. That will again add strength to the board as we drive forward through some really challenging times. With Councillor Aspinall and the new ICP, actually a real sense that we can build a strong sense of system working and system strategy to help rise to the challenges that we know our patients and our population face every day. It feels to me, maybe it's because it's January, but a sort of renewed sense of optimism and determination, actually, that we can work together in a way that helped our population to live the best, healthiest lives that they can, and a strong sense of teamwork, I think, building across the ICB itself, and building a culture of support for our staff and our wider system so that people can be at their best when they come to work in the morning. There's been a number of changes in the executive team structure, and I just wanted to highlight those today, and there's ongoing work here. But firstly, just to register that I think the whole board's ongoing thanks to Bill Shields for continuing to support Torbay Care Trust. He's now formally the interim chief exec until Joe Teep, the new chief exec, starts in March. So very grateful for him to be doing that. Also with Anthony Fitzgerald's departure standing down last month, we've confirmed some temporary arrangements in my report so that we don't lose any momentum. And I'm very grateful to John Finn, Kirsty, Sam Wadham-Sharp and Libby Ryan-Davies for stepping up in the interim to help us to ensure that we can keep going. We had a board development day in December, and following that discussion, we are looking at how we restructure going forward so that we can ensure we've got the right people around the executive table and into the organisation to deal with the challenges we face. So we are now seeking to appoint 2 new executive directors. The first, a chief strategic commissioning and planning officer, and I think that advert has gone out this week. And following up from that very quickly afterwards, a chief primary care partnerships and place-based delivery director, which again will enable us to focus both on those really important issues around primary care and also how we work with our partners out in the system. I've also set out in the plan the other very important piece of work going on at the moment, the engagement and consultation exercise going on in relation to the 10-year plan for the NHS. Again, having a real sense of where we're going over the medium term is going to be really important for how we ensure that our strategy aligns to that. We've had, I think, over 50 events across Devon now, and they have been really well attended. I think we've now had, although the report says about 1,000 pieces of feedback, I think that's gone above 1,300 now, and I'm really grateful to the public for giving us their views and helping us both at the Devon level but also at national level to really think about what the future might look like, what's good, what's bad and what needs to change. I'm also hugely grateful to our VCSE partners and Healthwatch for all that they've done to support this work, because it has been, I think, a remarkable piece of work in the short term. And I had the benefit of being at the Exeter Library this week to talk to some people there about their feedback and their experience, and I know other members of the board have done the same. I've also included a progress update on our agreed action plan in relation to safeguarding in the Torbay area. The board will remember we had a JTI and we had developed an action plan in relation to that, which we brought to board earlier in the year. I think, in summary, good progress is being made, and it will continue to be monitored through the Torbay Safeguarding Partnership Quality Assurance Group, and we'll ensure that we keep the board appraised of that progress. Additionally, we've put in a brief update this month on equity issues. I am planning that we bring back a fuller report to our March board. This was particularly in relation to discussions in Plymouth around how resources are allocated across the Devon system. I've had some really constructive conversations with the CEO of Plymouth City Council and her officers, and I'm looking forward to bringing that paper back to describe to the board where we are with that and the real sense of joint mission we have between the council and ourselves to make sure we do the best by the people in that deprived area. So we'll have that fuller discussion at the next meeting. I was going to give an update on winter, but I think it's been very eloquently covered by our winter director, and I would just call out in the discussion around the level of coordination and sense of grip and control across the system that has very much been led by Sam, and all the work that he's done to keep the system focused on improvement. There's only a couple of things I just wanted to highlight, and I think it is important for us, given, as Sam said, when you look at almost every indicator from the previous winter, we have improved as a system, with the exception of the Category 2 ambulance response times, which we are still working on. But it is important to remember that even in that context, we know that we are falling short of what patients expect and deserve, and also what our staff expect. So we are by no means complacent that improvement is enough. To pick up some of the points that were made, whilst we're learning in the moment, so we're trying to adjust and tweak our approaches in a live sense with Sam's leadership, we are also keen to do that much deeper sense of learning about what happened this winter, probably in the spring, in order that we can build a plan next year that really addresses some of those issues, and particularly around the demand at the front door of our emergency departments, really understanding what drove that and what else we can be doing going into next year. And then more broadly, and I think it picks up Tandy's point around the sort of sense that this feels a bit like pilots. The organisation was a bit behind the pace on the 6 programmes it had in place this year. Those things, including the virtual wards expansion, I think we've now been able to catch up on. But actually, there's a much more comprehensive piece of work now going on through the process of discovery, design and then deliver, to really understand what a more comprehensive Home First programme will look like and how we build that going forward. So building on what we've done, but absolutely trying to ensure that we got something much more comprehensive, and we will bring that back in due course when we've started that work around the design. And to link it back to the conversations with Plymouth, really keen for each of our local care partnerships to do that design work in partnership with them, so that we do it together. My report also includes an update on GP collective action. We know the history of this. We understand the reasons for this, and this being done, this being caused by real pressures out in the primary care system. You'll see in the report we are doing our very best to ensure that we understand what the risks are from the action and what mitigations will be in place, and that's being led by our Chief Medical Officer Peter, and we'll continue to update on how that develops. And finally, I've included an update, a summary of the work of the executive team since the last meeting. Sorry, that was a little long today, but there's a lot to cover. I'm happy to take any questions.
Thanks, Steve. Let's open it up for questions. I've got Judy and then Lincoln. Judy first, please.
Thank you very much. Could I just ask a question about the GP collective action and the financial aspects of it? So it is my understanding that when there was industrial action in the hospital sector, there was coverage from NHS England for the costs to the trusts of cover for the junior doctors and the consultants when they were on strike. And I'd like to know how much we got for that, either in the last year or over the strikes. And I'd also like to know whether there's any suggestion of funding from the centre to cover any of the costs we might incur from collective action, which is similar, in primary care.
I'll take that. I think in relation to your second question, we've got no indication that there is funding coming to cover the costs of that. That's not something that's been communicated at all to us. On the cost of the previous industrial action, so for this current financial year, 24-25, we had 2 million allocated to us. In 23-24, given that there was a much larger amount of industrial action, as you'll recall, I think the figure was just over 27 million for the system.
Thanks, Steve. Let's bring in Lincoln.
Yeah, I just wanted to make some comments on the Torbay safeguarding JTI, as we call it. First of all, just to reflect to the board the visible and consistent leadership we've seen in the past year in particular. Hannah Pugliese, Sue Smart, and Penny yourself. So that's been really positive for us in Torbay. One of the things that we've learned, and this goes beyond the safeguarding, as you know, we have a number of inspections and so forth. It seems in Torbay we go through this endless cycle. But one of the things that I've learned through it is the importance to ensure that activity leads to impact. And I think we've been very good, and this is a criticism of us in local government as well. We've been very good on doing lots of activity. We haven't been that good on demonstrating how this impacts on children, young people, on their parents and carers, and particularly in schools. And what that means is that the confidence that they have that things are available to them, which then helps change behaviors. And one of the key behaviors for us is the requests for statutory assessments, which puts people into a sausage machine because they feel that's the only way they will get attention. And I've spoken to so many parents and carers who've been let down so badly that even though we've done a lot of really good things, they still have this, you have to have that statement, or you have to have a letter from the GP, etc., or you won't get any attention. So I think it's still an area of great importance, and I would like to see the board reflect on it more explicitly. The way it was, and I understand it's just a summary, but it seemed a little bit too blasé and light touch, given the importance for us in local government. Thanks.
Yeah, absolutely not intended to be blasé or light touch, and we will bring fuller reports back. I think you're exactly right, Lincoln, that whilst we had to deal with the absolute importance of the JTI itself, the inspection, what that found, and make sure we had our actions in place, a wider focus on the needs of children, young people, and others is going to be really important to us as an organisation, and we do need to focus on the impact and outcome for them. We have to get this particular issue fixed because it did fall below standards for the reasons we understand. But that isn't the end for us, really. That's very much the beginning. I don't know whether Penny might want to come in.
Thank you, Steve, and thank you, Lincoln, for that pertinent challenge. So I link with the independent scrutineer of Torbay Safeguarding Children's partnership and met him just this week, actually, to really interrogate the quality of the evidence arising. So it's going to our Torbay Safeguarding Children's partnership in February the 10th, and will then come formally through our QPEC arrangements, so there will be a fuller report. But part of that discussion, Lincoln, was really picking up that. So what has really been the impact into practice? And we're going to have a joined up event to look at people's stories, but also not only but it is important around people's stories, but really pushing into that clinical evidence. So what does professional curiosity mean for a midwife? What does it mean for an ED consultant? What does it mean for a GP? And then, because it could be interpreted in many ways. The other point I'd want to raise is, of course, we've got new board members starting, and professional curiosity should apply to the board workings. And I've had some communication with Philippa around how we refresh the safeguarding training for board with a particular focus on professional curiosity.
Thanks, Penny. I'll bring in Frank now, please.
Yeah, it's not so much a question, but it's about the GB collective action. I think it's important from some of the other papers in the pack to realise that estates in general practice are 63% undersized without any plan for investment. And there are resilience issues for 27% of all our practices. Collective action is not the same as junior doctor striking. And what it is doing is surfacing a lot of the issues that have not previously been commissioned properly or are at the interface and no one really knows who's responsible. I think in terms of governance, the ICS is doing really quite well, led by Peter. In terms of the monitoring, it's really complex to monitor it, but I think what's in place is really good. And I think mitigations are appropriate at this point in time. And I'd just like to point out, again from the papers, that while we are in collective action in general practice is doing 14% more than it was doing pre-COVID. And in terms of how we're doing compared with the rest of the country, we're 20% more appointments than the average of the rest of the country. So GPs are not on strike, primary care is not on strike. We are just trying to get things that have not been commissioned before commissioned properly.
Thanks, Frank. I think it's really helpful, first of all, to just highlight the increasing demand on primary care services across Devon, but also to make that link to the potential commissioning gap, which is driving some of this. So thank you for that. Are there any other questions or observations for Steve? If not, then we will note the content of the Chief Executive's report, and we'll move on to item 2.3 on the agenda, which is the Organisational Development Plan. I see that Katie Curley has joined us. Welcome, Katie, but I'll hand over to Piers to introduce this paper.
Thank you, Chair. And, Steve's report, I think, is a good segue into this item because he talked at the very beginning of his paper the importance of future vision and culture. So we felt it was timely to bring an update to the board on how we're investing in both our organisation, the Integrated Care Board, but also in the wider system. So I'm just going to ask Katie Curley, who's our Head of OD, to bring to life the report. We'll take it as read, but if you just want to highlight a few things, Katie, and then we can go to questions. Thank you.
Thank you very much, Chair. Thank you, Piers. So thank you. The report that you have in your packs highlights both the current progress since we came to board in May last year, so progress to date, and also outlines a summary of our 25-26 proposed plan for organisational development, both internally within the ICB, but also with a focus to some system development, so how we work together as partners. The focus for our internal support, OD support, focuses on leadership development, and following our organisational change process, focuses on how we build new teams that have come together following that org change process. Culture is a key thread throughout the paper and the planned activity, and as part of that we'll be developing a values and behaviours framework for the ICB, which feels really important at this time. We'll also be looking at how we work together across the organisation. So we are 30% lighter. We need to think about the opportunities we have to maximise the resource that we've got within the organisation to its fullest. So how do we ensure that we're working as effectively together across all directorates? So we'll be doing some work around that as well. Externally, thinking about system development, there are two key priorities. One is to support the development of a behavioural compact, and this, again, is to support partners working together, thinking about our behaviours when we're coming together as system partners. And we will be using the national tool that's within your packs as a foundation for that work. But in Devon, we want to take that one step further. So we're looking at how do we embed that? What does that look like in reality? What are the real life examples that we can use to bring that to life? And how do we create an accountability framework that sits around that, that allows us to hold ourselves and others to account when those behaviours aren't in play or that things don't go quite as we've agreed to? So I think that's a summary of the paper. I'd be really happy to take any feedback or comments from the board. Thank you.
Thanks, Piers. Thanks, Katie. I'm just going to bring in Steve before I open it up to questions and observations from the board.
Yeah, I know we have a number of things on the agenda today, sort of focused on our plan for this year, our plan for next year, developing a strategy. In some ways, none of that matters if we don't have the right culture, the right organisation and the right ability for the system to be able to work together effectively. For those of you who are at the Michael West event, it wasn't just about how we're compassionate to ourselves and others. It was also the very strong evidence base that the best organisations, the ones that can achieve targets, that stay within their money, that have good quality and safety, are those that have really strong sense of teamwork, that people know which team they're in, they know their voices are heard and they're supported in that. So for me, this feels is existential to us as having a really good plan, and it starts within the ICB, and I've been absolutely delighted with the work that Katie has led for us with bravery, coming into our team meetings and pointing out elephants in rooms to us and so on. The exec team itself has had its first a period of time away together to think about how we are as a team and how we become a really high-functioning team ourselves. And we're looking to deploy that across the ICB as an initial next step to ensure that we can do the very best in that for our people. And actually, it makes coming to work, being creative, a much more pleasant experience, and we know we probably could all do with that. We've also started the work with the CEO community across the system. So Katie and a few of our colleagues from our providers got together with the chief execs recently, and we started to explore our team working together as well, because again, I think the importance of how the system works together in this very complex system is really important. So sometimes I think OD can be seen as a bit of a nice to have. I think it's absolutely core to how this organisation and how this system will succeed despite the challenges that we face.
Thanks, Steve. So I'll open it up for questions and discussion. I've got Lincoln and then I've got Graham. Over to you, Lincoln.
Good. Thanks so much. Really good report, and really happy to see the focus also on the system development. And by system development, I'm deliberately reading that as the non-NHS partners, so that your chief executive group, I would be hoping that chief executives of local authorities and VCS representatives are part of that. I wanted just to point out that when we move forward, because we're human beings, there is always hindsight and your past experience. And my observation is not that I'm precious about the particular methodology, the outward mindsets. It's about the principle that we didn't feel that we ended that properly. And it was something about honest, open, if you're going to engage, then there is something about how do you speak with your partners about why you make critical decisions. Yeah? And as we go forward, whatever methodology, that we have a sense that we're doing this all together. And that we're using this as an opportunity to build those relationships that mirror the ways in which ICB core executives and others will need to work with partners to deliver some of these things that matter to our residents. Thanks.
Thanks, Nick. And I wonder if Piers or Katie would just like to respond to that point about outward mindsets and how we move from the, from what we were doing a year ago to what we're now doing.
Yes, thank you. Thank you very much, Lincoln. So yes, the outward mindsets work was a large piece of work that we had commissioned with partners. I have to be really honest; it wasn't universally valued by all. And so there were some people that really didn't want to engage with that work, and there were others that really valued it and really liked it. What I will say is that it hasn't gone away. So we invested in more of a sustainable approach around outward mindsets, and we still have 10 facilitators across Devon who are trained to deliver outward mindsets. It still continues in pockets, and we're working very much with some system partners around that. For example, the methodology was used recently with a consortium of health, local authority and BCSE groups to support them around some tensions that they were having in a commission service around homelessness and addiction. Now, we have opportunities to continue to use outward mindsets, and I also use that as almost a toolbox within my facilitation methods. So I will use parts of outward mindset as we continue to do that. It's also much more suited to a system development environment rather than an internal NHS Devon environment. Although it can be used to bring different teams together, it works really well and comes to life when you've got different partners in the room and you can get behind someone else's view, someone else's lens of the world and really understand that and start to dig a bit deeper. But it does require people to be a little bit vulnerable, and on reflection, I wonder if we had created a safe enough environment to allow people to really engage in that previously.
Okay, thanks for that clarification, Katie. Piers, do you want to come in on that point before I bring in Graham?
It's a really good point, and we, looking back is important because we don't lose the positive things that we've done either. So I think Katie's given a really articulate response to why we are where we are. But the only thing I'd add is that, Katie said in her presentation right at the beginning that we have to be conscious too that we've got 30% less in the Integrated Care Board, not just in terms of people, but in terms of funding, and so and similarly providers are also across our system also challenged financially. So the way in which the methodology that we use and the way that we engage through OD has to also be an effective and efficient model. And so the previous approach was very costly, and we should understand that. And so we're trying to adapt to the climate that we're now operating in and be as effective as we possibly can with the resources that we have. But I also want to reassure you that we're not losing, just as Katie said, we're not losing the successes of the past and the methodology in some ways because of our investment in training people to become facilitators isn't therefore lost. Thank you.
Thank you, Piers. So I've got Graham, Penny, Frank and Tandy. So over to you, Graham.
Thank you so much. So I think we all recognise that service performance improvement along with resource constraints equals productivity gains of some magnitude, and that in turn requires doing things differently. And I know we've got other parts of the agenda looking at transformation, but I see, I think like Steve, that the OD piece is a pivotal piece in enabling that to happen. So I'm a big supporter of it. But I wanted to just talk about capacity to do it, because the paper references the capacity within the team and the resources, which I think means funding. But actually, the bulk of this work will fall on all sorts of people across the system as a whole. And we all know the sorts of daily pressures that you get and the barriers that can prevent attention in this area. And so I just wondered whether in that risk section we should more explicitly reference the capacity requirements to ensure that we are making that available and protecting it. I didn't quite understand what the 18% cited there is, but I just like to make the point that really focusing on understanding the barriers to enable the capacity to be provided is really essential to achieve the changes we all need. Thanks.
Thanks, Graham. Piers, Katie, do you want to pick up that point?
Yeah, Katie might have the specific answer to the 18% point, but in essence, if I've understood your point correctly, is the understanding of the wider risk around the engagement of people, not just those that would be facilitating development, but those engaged in it too. And we are very conscious of that. I think that's probably one of the features why we've had to move on from historical approaches, because the investment of people's time can be considerable, and if that and we have to balance that between developing our people, which is vital to success, as you said at the beginning, and Steve articulated really well too. If we don't become high performing as a system and organisations, then we won't deliver the very challenging year that we've got ahead of us and beyond. So we have to balance the investment of people's time in engaging in these processes against the importance of them being able to run their operational services. And to give a more general answer to your question, Graham, we are very aware of that. And the approach that Katie's been talking about and the design of the system organisational development approach will include partners, so that we're expressly aware of the amount of resource that people can put to it as well. Katie, do you want to answer the specific point?
Yeah, thank you, Piers. The specific point around the 18%, so there's some research that's been carried out that identifies, this is in association to culture, so this is about when people are working under in an environment where there is a lack of trust, there's very low morale, they're feeling very, very stressed and depressed at work. It can affect their productivity to the cost of around 18% of their salary. So if we times that around a number of people, so it's putting a cost against the value of investing in supporting developing our culture and improving the culture that we have.
So isn't there a danger that you were saying on the one hand there's a risk that productivity goes down, but actually we want productivity to go up, so the delta between those two becomes even greater? Yeah. So I'm still, I think, of the view, which is I would advocate a specific explicit risk in there about capacity.
Yeah, okay, thanks, Graham.
Yeah, I think that's a fair point, Graham. Thank you.
You understood the point Kate was making. It is about productivity, and that is going to be a key feature of our operational planning going forward, maximising the outputs with the resources that we've got, and probably depleting resources. And part of that is to create culture and all the things that we've just been talking about, so that people feel able to operate at their absolute best. And we must not forget that, and so that's why OD is so important, both for us as a board, but also for us as a system. Thank you.
Thanks, Piers. So I've got Penny, Frank, and then we'll take the last comment on this from Tandy. So Penny first, please.
I'll go promptly, but I have 3 points. So number one, to really applaud the work. As a chief nurse, obviously I represent nurses, AHP, midwives, who account for a huge part of the working population in Devon across wider NHS Devon. And we know, although you say, Steve, it can be considered as being an added extra, we know the clinical impact of closed cultures. So not only from a productivity perspective, but from a safety perspective, this is really important for our practice. I really applaud, again, the fact that you're applying it into our work, because I think the danger with OD, it is seen as something separate too. And I think the way that you've built learning and development into the programme is absolutely essential, because we need not only to be productive, we need to be competent and capable. So learning together will be great stuff, actually. And then I think the final thing I'd want to say is, let's be clear that our staff survey isn't great. And we reported on that last year. I would really like, and we know this work started partially in response to that. So I think, when we look at high-level inquiries, for example, it's very often the staffing metrics and the culture metrics that go off first and are your biggest early warning system. So I'd really like to see more explicitly the connection with our staff survey recovery work, and I know the results are marginally better this year. So thank you.
Thanks for that, Penny. And do we agree, peers, that to make that link more explicit in the plan?
Yes, absolutely.
Yeah, thanks very much. So I'll come to Frank next, please.
Thank you. I'd just like to commend Piers and Katie for this. I have a number of mantras, one of which is culture and climate matter more than systems and structures. We spend all our time doing systems and structures, and the culture and climate is really, really important. The core values on page 53, I think, are great, and the one that has already been mentioned by Penny about professional curiosity is probably one that you don't normally see in core values, and I think it's really, really important. So well done and thank you.
Thank you, Frank. And Tandy.
Yeah, as the ex-chair of the original People and Culture Committee, I have to say this is really, really good. And I think that I would have been really pleased if we had been looking at something like this when that committee was in place. Versus, I thought most of what we'd been looking at then was the piloty stuff. Versus now, it's looking like really whole organisation and system and all that. So thank you for that. But just coming to the outward mindset piece, I mean, are we going to reflect on why some people didn't really take to this? Because it wasn't a cheap programme by my recollection, and I think that for what was spent on it, either we need to understand why it didn't really take off, or we need to learn so that we don't commission something like this again where we only get half the bit back.
So that's a good point about the learning that we took from what happened on that. I don't know, Piers or Katie, if you want to quickly just respond to that.
Yeah, no, just very quickly, that is precisely what I was trying to say to Lincoln earlier, that we have tried to learn from the experience and make sure that this programme, therefore, gets a better balance of investment in time and capacity, both from a facilitation point of view, but also from system partners' engagement in the process. It's also a much more affordable model than it was before, and we can't underestimate the importance of that, and that is a key feature of why you can't always continue to invest in things that are tremendously costly. Have to cut our cloth, don't we? So yes, I think we're trying to give you some assurance that we have learned from that. Thanks.
Thanks, Piers, and thanks to both of you, Piers, Katie, for all of the work on this. And just to echo comments around the table, the board does applaud the work that's being undertaken on this. You've given us some actions to take as a board. The first one is that we take satisfactory assurance from the update provided on the progress against the OD plan and the plans for 25-26. Are we content as a board to take satisfactory assurance from the paper in front of us? We're asked to note the identified risks and mitigations which would continue to be reviewed. Are we happy to note that? We're asked to then approve the adoption of the NHS England Code of Conduct in respect to system working, noting that work to develop a Devon framework for embedding the behaviours was ongoing with system OD leads and senior leaders. Are we happy to approve the NHS England Code? Okay, the board approves the code. And finally, we're asked to note that regular updates on progress of the delivery of the OD plan will be provided to the People and Organisational Development Committee. And I'm guessing we'll take regular updates from that committee at the board each time we meet. Thank you for that. Let's now move on to the National Oversight Framework, Section 4, part of the agenda. And I'll ask Sam to take us into his paper. Thank you, Sam.
Thank you, Chair. So this is the progress report against our exit criteria to exit National Oversight Framework Segment 4 in line with our revised timeline, which is Q1 of 25-26. And it's a report that looks at the 5 different exit criteria and the progress and assurance levels within. So there is obviously the paper as per normal, which needs to be read in conjunction with the highlight report. And that highlight report has been already discussed and reviewed at the Devon System Improvement Assurance Group on the 8th of January. So this is currently a report for all of the exit criteria progress for November for all bar elective, which is October due to the normal time lag in terms of the performance data being available. It should be noted that due to the time of this meeting, the update paper for the December performance has now been written and submitted. So if there are any questions that you would like asked around following further updates, and that I'm happy to give some further information towards the end. So the paper provides the assurance levels in line with our ICB assurance criteria, whereas the highlight report provides the action review and the RAG ratings in line with the RSP RAG statuses for the month in question. So in terms of any changes from the previous report, there is one change to the RAG ratings within the highlight criteria, which is for our urgent and emergency care criteria. And that forecast has turned, the end of year forecast has turned red based on the fact that we have made progress, but there are significant gaps and widening gaps between current performance and trajectory, and it would seem not the right thing to do to turn it anything other than red at the moment, particularly as we are in winter. So in terms of going through the actual 5 criteria themselves, so leadership remains both satisfactory, amber for in-month and green for the end-of-year forecast, and there is detail in the paper on the integrated care partnership refresh, the process to appoint the chair, which obviously happened since this paper was written, and also some detail on the board development session, and that undertook a review on the purpose of our provider collaboratives. Strategy remains satisfactory for in-month, amber for in-month, and green for the end-of-year forecast, and there is some detail within the paper on the clinical review process linked to the fragile services work and the work to finalise the activity and financial modelling that will be undertaken by the end of Q4 in line with the metrics. So UEC, as stated, is limited for assurance, is red in month, and we have changed that red for the end-of-year forecast. For our performance for the system level within that month was 68.43%, and performance unfortunately worsened across all 3 of our acute providers within that month and recorded our lowest performance in that particular year. It should be noted that when you do reflect that against November 23, that was 62.9%, so we have seen improvement within the year, so I think we should be noting that. There were improvements from October into November on ambulance time lost and the percentage of ambulances handed over within 15%, and all of our criteria within November 23 bar category 2 response times were better this year than they were last year, so I think it's important to note that progress, but not where we want to be. In terms of elective performance, so we remain satisfactory assurance within month, amber and green for the forecast at the end of the year. So we have reforecasted trajectories to and the requirement to meet 0 78-week waiters in December and 0 65-week waiters in March. In terms of the October performance, RDUH and UHP narrowly missed their 78-week projections for the month of October, but all of our providers met their October 65-week projections at that particular point in time. In terms of, again, looking at where we were in October 23, the system view for October 24 was 85 78-week waiters versus last year's position of 784. And within 65-week waiters, it was 959 in this October versus the previous year of 3,985. So once again, I think we can see the progress that has been made in those particular areas. In terms of the ask to meet 78-week wait 0 in December, it looks as though Torbay met that target, but unfortunately RDUH and UHP did not meet that target, but they still plan to clear those within the year. And in terms of the 65-week position by the end of the year, Torbay is still forecasting to meet that target, whereas UHP are currently forecasting a risk of 29 patients and RDUH are forecasting a risk of 190 patients. So significant progress, and I think we are moving in the right direction, but risk remains to hitting that 0. In terms of finance, noting that there is a separate finance paper on the agenda, so that remains satisfactory in year, red for the current month RAG rating and amber for the end of year. So month 8 finance performance was in line with the plan for the system, which was also reforecast within that month. Efficiencies of 103.7 million to year to date, which is 9.6 million above plan. The forecast for those efficiencies are 57% of them have been delivered recurrently against our original target of 70%. And just also to note that there is a note within here around pay expenditure, which is 16.3 million above plan, but it should be noted that we've also brought in 8 million additional income with that overspend, which offsets some of that due to our push for elective activity. So I'm happy to stop there and take any questions, Chair.
Thank you, Sam. And Martin, this paper was discussed in quite a lot of detail at the Finance and Performance Committee a couple of weeks ago. Is there anything you want to add to Sam's summary there?
Yeah, I can give a bit of feedback, Kevin, if you like. So I suppose at face value, committee went through the report, heard a bit more detail than we've heard here today, was happy to support the levels of assurance given in the paper. I suppose beyond that, and giving it a bit more flavour, I think it's fair to say that we probably expect a bit more positivity than you can pick up. Just broadly looking at the sort of reds and where we're still at. And if you take a step back, certainly from my point of view as someone relatively new to the board, I think strategy and leadership, we're very strong on now, much improved, I'm sure, from where it was before. So I would be very optimistic that coming towards the year end, anyone who judges on that would find us favourably. Elective clearly going the right way. Yes, some of those trajectories might not quite dipped yet to the right level, but no one can say they're not going in the right way and are likely to achieve, given a relatively short amount of time. Finance, as we said, underlying position, still, deficit with the system, but, the key thing is to set a plan for the year and then deliver it, which looks like we're on plan to do from my point of view. And again, UEC, whilst we're still red and, was willing to accept and sort of back, the red projection for the year end. We've heard about, things that have been done system-wide, growth in activity and attendances, respiratory illnesses this year, norovirus. So, perhaps some mitigation, but also some strength in the work we've put in place. So I think fair to say the committee was satisfied with what we put in the paper, but also underlyingly optimistic, let's say, that, we ought to be able to push as a board. I don't know what the process is, but to hopefully move out of some of these not-full metrics at the year end.
Thanks, Martin, and thanks for the work that your committee does on it. I'm going to bring in Graham, and then I'm going to ask, and then I'll bring in Sam, and then I'll ask Steve to make some comments on this as well. Graham.
Thank you. So I think we talked about green shoots going back a couple of board meetings ago. I don't know what the next stage of vegetation development is, but I think this is a firmer view now of improvements. The one area I would just like to pick up a bit on here, and it might also reappear in the finance paper, is yes, we are within our numbers, but there is a change in the balance between them. And actually the favourable variances, both in terms of outturn and SIPs, are in the ICB, whereas there's an adverse in a couple of the acutes. So I guess what I just want to make sure is that we all subscribe fully to what we're measuring as the not-for exit. Can we just check that we aren't going the wrong way in terms of the shift to the left, and that the savings in the ICB isn't actually at the expense of reducing some of the services we actually do need to enhance? So can I just ask to get their assurance around that area, please?
Thanks, Graham. I will just ask Steve to respond to that specific point that you've made.
Yeah, thanks, Graham. I think a really good point, as you mentioned. We are seeing some pressures, as I think we've talked around this table before, particularly in one of our providers, and that's why we've put in additional system support to help them. I do think it is something, whilst we need to focus on ensuring that as a system we reach our deficit target that we signed off at the beginning of the year, and in doing so the system working together in a way that perhaps we didn't plan for in the beginning of the year given those pressures, that as we exit from this year and go into next year, and it's partly Martin's point around the underlying position, that we ensure that we try to rebalance how the system is going to operate from next year. It's going to be, if I'm being really frank, it's going to be difficult this year to do that because we are where we are and we're having to deal with a significant financial challenge, but within the context of continuing to deliver our 80 million. So I think it's something we need to be very mindful of when we are developing and talking to the board about what our 25-26 plan is, both for performance and for money. I don't think we'll recover it all, but I think we need to ensure that we aren't losing the opportunity to shift left, as you say, because in the end, that's the thing that's going to keep us safe in the long term.
Yeah, thanks.
Thanks, Steve. I'll bring Sam in now. Thanks, Sam.
Thanks, Chair. So we also discuss this report at my board every month. We have some quite interesting discussions about it. And I just wanted to reinforce Martin's point really on the finance section, that the discussion we had yesterday at my board about this was they feel that the current red ranking does not reflect the fact that half the ICBs in the rest of the country are off plan, and we are continuing to forecast a delivery against plan. So I just think it's important to note that whilst we've got a lot of stresses and strains to get over the line, we are actually making real progress and going in the right direction here.
Thanks, Sam. And it is important to continually benchmark ourselves against the rest of the country, isn't it? So thank you for that comment. Steve, any final points on NOF4?
Yeah, thank you. I'll just pick up Sam's point because we've had this discussion a number of times, both internally and with our regional colleagues. Partly these RAG ratings are a sense of gut feel. Rather than the absolutes. And I think if you looked at the absolutes, actually we probably should be in a better position than red, but there's just that sort of gut feel that we're not there yet. And particularly with some of the emerging challenges, as we know, through this financial year, that's felt right. I'm hoping we can have a different discussion with Region at our next meeting with them. Just a couple of general points for me. Yeah, I guess it is always difficult to... you don't want to overstate things, but I've said, I think, to the organisation and indeed around the exec team table that I feel cautiously optimistic, which is just begging fate to do something different to us. But even so, I think there is a sense that we are moving absolutely in the right direction. Of course, the point's been made quite often by Sam, actually, that we were never set a set of relative exit criteria. They were absolutes, and actually that in itself is a challenge when the tide is rising for everybody and every system's finding it difficult. And actually in relation to that relative position, as well as some of the absolutes, as the other Sam has said, we are improving. That does feel quite difficult. So I feel cautiously optimistic because whilst we haven't been able to hit potentially the letter of some of these criteria, we are at least hitting the spirit of them, and we can demonstrate, I think, two important things: continued persistent improvement and also a greater and more enhanced ability for the system. That's not just the ICB, that's all of us together, to be able to sort of roll with the punches, find solutions as we go along and solve our own problems. And I think a system that is able to do that is starting to show that maturity, should give NHS England more confidence that actually we can deal with these things, knowing that the challenges ahead are at least as big, if not bigger, than the ones that we're already dealing with. We've just held the latest of our locality planning and delivery group meetings, and whilst recognising the real challenges around UEC, and I think it is right that it remains red for now, to say that all of our providers confirmed their forecast year end on the 4-hour target to remain the same. So we are still running to get to a 78% position in March, albeit it won't be against the trajectory that we set out at the beginning of the year. So even on that one, I think we haven't given up. So I look forward to the debate with the regional team and the RSP team. I think it's been great how they've been alongside us on all of this, and I would hope that in some of the sort of softer mood music around the place, they can see actually that we have demonstrated that we can do these things, and maybe NOF4 is not the place we need to be anymore. But Sophie's smiling. I'm going to stop there.
Thank you, Steve. So we've got two recommendations in the paper. The first one is that we agree the assurance ratings relating to progress against each of the NOF4 exit criteria. So for the minutes, these are satisfactory on strategy, on leadership, also satisfactory, UEC, limited assurance, satisfactory assurance for elective, and satisfactory assurance on finance. Is the board happy to agree those assurance ratings? Thank you, they are agreed. And the second recommendation is that we take assurance that adequate plans are in place to mitigate the risks relating to the delivery of NOF4 exit identified in the locality planning and delivery meetings and the system leadership group. Are we happy to take that assurance? Thank you very much. We're now moving on to the section 4 of the agenda for approval or endorsement, and our paper in this section is the primary care access recovery plan. I see that we're joined by Paul Green, but John Finn is going to introduce the paper. Thank you, John.
Thank you, Chair. So the paper, as you say, is in relation to the primary care access recovery plan. So I'll take the paper as read. However, I'll summarise the key points, and myself and Paul, as the Director of Primary Care, can take any questions after that. So in summary, Devon does comparatively well in access. We obviously know there's variation, and we continue to address this with absolutely no complacency. So we, the primary care team, look at signposting GP practices into the General Practice Improvement Programme nationally, an excellent programme in terms of the consistent and continual review of looking at access, workforce, patient surveys, QOF, to understand where those challenges actually are. So the report provides assurance that we're on track with the PCOD requirement. The focus into next year will absolutely be on two-sport transformation in this area, which I'm sure every board member will understand the importance of that. So in terms of assurance, with respect to the tables on page 7 and 8 in the paper, the detailed headlines in terms of assurance actually are in slides 8 to 11 in the main body. But in terms of the actions to move from amber to green, I think it's important that I do cover some of those. So in terms of empowering patients, the increased pharmacy first clinical pathway consultations, we have a brilliant national campaign in this area, and locally we have videos, bus adverts, social media to improve that action, and we are seeing improvements. The second one, an increase in oral contraception prescriptions coming from community pharmacy. Now, our PCN pharmacists work really closely with community pharmacists in terms of ensuring that the capability and capacity to increase this is in place. In terms of building capacity, to continue with expansion and retention commitments in the long-term workforce plan, that we have workforce plan at PCN level and a GP Reconnect scheme to support this. So focusing on the implementation of the modern general practice component, there's a capacity and access improvement payment CAPE, which is specifically focused on supporting the 3 domains of the modern general practice model, access model. They are better digital telephony, simpler online requests, and faster care navigation, assessment and response. Now, these components need to be in place in every practice as part of a PCN, and that is causing some challenges in terms of delivery. And as part of the BMA recommended actions around collective action, there's a position for PCNs to defer signing the declaration of completion for simpler online requests, which is also impacting on our achievement of this standard. So that's my summary. I said happy to take any questions from myself and Paul.
Any questions and observations for John or Paul? Judy.
Oh, sorry. I thought you said somebody called John first.
Sorry.
That's okay. I would like to say well done to the team and well done to General Practice, because it is true that our appointment position is very good in Devon. I would like to note urge a note of caution around this. We're sort of measuring one area of general practice in this report, which is access to general practice. And if you think about it, and if you think of your own personal experience, if you can have 15 to 20 minutes with the GP, you can get an awful lot more done than you can in 5 to 8 minutes with the GP. And one of the things that's being introduced in some practices to cope with this business of needing more appointments is these shorter appointments where you deal with one issue. And as you get older, your issues become more complex, I can promise you. So one of the things we have been trying to do is develop a measure of continuity of care. So for some people, they wouldn't mind waiting a bit longer for an appointment if they can see the same person or if they can have a longer appointment, because then they can properly balance the different conditions they have and get a good way forward and not need to keep coming back for appointments. So as we go forward, this work is incredibly important. I'm not denying it, and people are doing really well. But we need to keep thinking in primary care in more complex ways, in the same way as we learned in the early days when we started measuring waiting time in A&E departments and discovered that actually it was pretty difficult to get some people through in the time requirements. So can we please be on a learning curve? And can we also really note, and the reason I asked the question earlier about primary care and funding, is that primary care's percentage of the funding, we've raised this at the board before, in the NHS as a whole has gone down in recent years, and the impact this is having on estates, I've been having long conversations with Kirsty about, and I know Frank has, about the importance of estates and the importance of workforce development and other things that are very hard to be done when the cost increases that are allowed are not meeting even anywhere near inflationary pressure. So this is great, but let's not sit on our laurels, please.
Thanks, Judy. Good point. So I've got Sam, I've got Frank, and I've got Phil. I'll bring in Sam first.
Thanks, Chair. There's always a danger with these reports that because Devon is such a large place, we look at the average, don't we? And we've already talked a bit about in this meeting that we know we've got some particular areas of concern around the county, and particularly worried about some aspects of primary care in those areas of concern as well. So I suppose for me there's a bit of a conversation about what are we going to do where we know we've got demand problems. The other bit is none of us are going to come out of the other side of the 10-year plan consultation with a set of organisations that are constituted in the way that they currently are today. So I think there's a conversation about where is the strategic thinking and conversation going on with primary care about how are we going to evolve going forward into a different service model.
I think I'll just bring in Steve to respond to that point. Actually, Sam, if you're okay with that.
Yeah, I think that it's a really key question and probably something for the Devon system and maybe more generally hasn't been fully addressed yet. I think all I can say at the moment, Sam, is it's absolutely on our agenda to, in the end, what we need is a single strategy that pulls together all of the work that's going on around the acute sustainability programme, the acute collaborative, but also a really clear strategy for our primary and community. Think, what can we do close to home? What does that mean for a modern primary care service? And ultimately, all of that built on prevention and community resilience and population health. We're bringing a paper back in March, which partly tries to demonstrate that all of these things are in different places in terms of their development and maturity, and how we're going to bring them all together this year into one coherent plan that addresses the whole thing. But probably fair to say, in terms of primary care, we're at the early stages of that, whereas in other places we're further ahead.
And it links back to Frank's point that we won't be able to deliver modern primary care unless we've got proper estate and proper digital infrastructure, will we? So it's complicated, I recognise that.
Thanks. Yeah, and I would just say, sorry, if a strategy is only the start. How you implement it is really important, and all of that stuff would have to be addressed.
So Sam's point about the averaging in this paper, is there anything that you want to flag up on that, Paul or John?
Yeah, if I can just briefly, Chair. So you're absolutely right, Sam, of course. You know, you look at Devon level, and we're here, aren't we? I guess that the couple of things I would say is in terms of if we look at our sort of 4 systems of Devon, they are all now above national average. But you're absolutely right. That ranges from about 4% above national average to about 28% above national average, and therein lies the issue. One of our key targets for next year is about getting all of our PCNs to a position where they are all upper quartile in terms of national performance, if you like, in terms of access. So we want to sort of maintain the access where it's strong, but reduce that variation. So at system level, we're also in a comparatively good place. The key thing is around addressing PCNs, and you'll be cited, I think, on the sort of test the change that we've got in place at the moment, one in each of those systems around what we're sort of calling new model of general practice. And absolutely fundamental to that is the incorporation of those 3 CAPE themes that John mentioned. So we've made them sort of must-dos, I guess, for those new change models, and not to get wildly carried away about that because it is early days. But looking at the data this morning, 2 of those 4 have just seen the lowest day in terms of demand on other parts of the system that they've seen for the past 12 months, which is only an encouraging sign at the moment, but I think does illustrate the importance or the potential that exists by prioritising those PCNs who have at the moment, as you say, the greatest degree of challenge.
Thanks, Paul. So let's bring in Frank and then Phil, and I think Judy, you wanted to come back in as well. Frank first.
Thank you. Access for patients is really important. I keep going on about the fact we're here for people and they're unwell and want to be seen. So I absolutely accept that general practice needs to do better. But general practice is part of a system. We are seeing more than we were, but we've been driven to see things acutely. And taking Judy's point, that drives continuity down. We see about 50% of them on the day that they contact the practice. The target is only 35%, so we are overperforming in terms of access against the target. What that then leads on to is reduced continuity, and all the research on continuity was done by Dennis Pereira Gray. It reduces death rate, it reduces medicines used, it reduces attendances in general practice, it reduces attendances in emergency departments, and it reduces admissions. So we do absolutely have to go with how we improve continuity as well. I think the most important thing is demand will probably always outstrip supply. But I said at the beginning, we're a system. As the system improves, we will get much better access to primary care. A lot of my day is failure demand of other bits of the system because the patient can get into me. So the improvement the system is making is helping general practice massively. And the more we can drive that, the better.
Thank you, Frank. And can I bring in Phil, and then we'll have the final point from Judy.
Thank you. When I read the paper, I zoned in on the strategic metrics because I interpreted those as the ones where we're sort of stepping back and saying, are all these things we're doing having the impact that we really need them to? And it might be me misunderstanding, so apologies in advance. The data set looks a little bit out of date against some of the things like appointments within 2 weeks, and therefore I was just left with a bit of a question of, we've got lots of process measures that are green and amber, but it doesn't look like we've got a measurement that knows whether we're having the impact on something like that, appointments within 2 weeks. And I was also curious, and I think the answer is it's really difficult, so no, to understand the impact of the GP collective action on any of the access measures that we might have, i.e. is improving them or not.
Thanks, Phil. John?
So if I can start with that and then bring in Paul. I think showing cause and effect in anything in primary care is very difficult. I think in terms of the matrix and the data, it does lag behind. And I think it's something that we've been reflecting on the team, basically, that a lot of this information is based on last September rather than now. So I think we need to take that on board. I think it just, as Sam was saying about our UEC 6-pointed plan, basically, being able to show impact is really, really important, actually. We'll need to review the data sets that are able to show us that. Maybe on the second point, I can ask Paul.
Yeah, thanks, John. Just very briefly on the data lag, part of that is about the reporting cycle as well in this instance. So this is a national programme with specific data reporting points. Were we to be using the most up-to-date data, Phil, we'd be using November's. So there is a lag, and it's not inconsiderable. Actually, we probably have just received December's, but it is exaggerated, I think, because of the reporting cycle here. Happy if away from here, Phil, if it's helpful to give you the refresh of that. In terms of GP collective action, it's interesting because there is no simple answer, as you allude to, Phil. 117 practices not acting in a wholly consistent way, as is the nature of collective action. Broadly, as a headline, though, we've seen a slightly less than 2% decrease in terms of raw GP team activity. Nationally, that's about 5%. So that is good, I guess, if we're thinking about the raw offer. What we've seen as a bit more of an issue locally is sort of targeting of specific action areas. So rather than the raw offer being particularly targeted, it's more around services which GP leaders would describe as non-commissioned or inadequately commissioned. So thinking about your area of expertise, your world, things such as stepping back from some of what you and I might term shared care arrangements for antipsychotics, for example. So it's more around specific areas than impacting total access, if that makes sense.
Thank you, Paul. And let's just bring in Peter for a final comment on this.
Which is helpful, Chair, thank you, because I think it's a reflection on what a number of colleagues around the table have said, which is strategically, the more that we can describe a strong neighbourhood offer to our population that is agnostic to whether we call ourselves primary care or community care or hospital care, and we just talk about what is the care that we can provide close to our population, what specialist care can we not, and how do we start to shift from those input measures to the real output measures. I think strengthening our population health understanding, how we use the data that we already collect to really be able to describe what is an impact of how we do big service transformation is the key to how we get ourselves out of the issues that we face ourselves at the moment. I think trying to fiddle with each individual component is not going to be as helpful as trying to reconstruct the whole, and I think that that's the plan as we move forward for the next year.
Thanks, Peter. Very helpful. So, in the context of that, this is taking one aspect of primary care in terms of access, and that, as we've heard, primary care is more complex than just access. And the point Peter just made around the connection of this in strategic terms to the wider service transformation, we do have an action here in which we're recommended to take satisfactory assurance that the PCARP delivery is on track in Devon. Are we happy to take satisfactory assurance from the paper? Thank you for the work on it, John and Paul. Thanks for your attendance at the meeting, Paul. We now have a break. It's scheduled for 15 minutes. Can I ask that we take a break for 10 minutes and reconvene here at 11:22? And if we can pause the live stream for those 10 minutes, that would be great, Josh. Thank you very much. going. Thank you. Okay, welcome back, everybody. We're now into the section of the agenda on governance, performance and assurance reports. And what I'm proposing is that we take items 5.1 and 5.2 together. And so I'll first invite Penny to present the quality report, and then I'll invite Tandy to report from the Quality Committee of the 16th of January. And then I'll open up for questions to both Penny and Tandy together. So over to you first then, please, Penny.
Thank you, Chair. So, as usual, I'll take the report as read, and also to note that there's been prior consideration of the quality report and the Quality Patient Experience Committee. So, key areas I want to bring attention, or the board's attention to. So, first and foremost is around safety, particularly around our urgent and emergency care. So this very much talks to our NOF4 status and obviously our key priority area. So this was subject to review at the System Quality Group earlier this week, and also at the Devon Clinical Cabinet. It was a key meeting actually, because we reviewed all of the national cascades relating to safety as well as performance in the field, and checked our response. Also, it looked at our approach to dynamic risk assessment, and this is a complex area of work, however, really important for Devon, noting the situation we sometimes find ourselves in. The other area then for your attention is that we are achieving the requirements for the Patient Incident Report Framework, which is the move away from the National Serious Incident Reporting Framework, and that is progressing. There is still more to do, so all of our providers have now transitioned. I think for us it's the challenge of how do we make that, push that into the improvement space, and to note that that's going to be subject to an internal audit. The other area I'd like to bring your attention to is infection prevention control. So significant work has been undertaken here with the now newly instituted Health Protection Delivery Group chaired by John Trevaines, and some really long-standing issues around issues such as avian flu and tuberculosis are being addressed effectively in that space. We are seeing a small rise in C. difficile, and that's going to be subject to in-depth report and will be subject to further board reporting in due course. Finally, from my perspective, maternity. So it's important to note in the record the role that the ICB has played in the sign-off of the CNST submissions, and I have been to 2 boards to date to support provider declaration, and I will be in UHP next week, or United Hospital Plymouth. So the other area I think is to note that we've got a separate report arising around children and young people and the autism waiting list, so I won't pursue that further at this time.
Thanks, Penny. And the quality report that you've just presented was considered in detail at the previous Quality and Patient Experience Committee, so I'll invite Tandy to highlight any matters from that committee which are pertinent to the discussion of the board today.
Yeah, thank you. You've got the Chair's report, which I will take as read. A few things to highlight. So we did look at the commuter waiting list, which we've just looked at now, noting that for us, really, we are looking at getting more to grips with what's happening in that space to get to par with what we've been looking at in terms of acute and waiting lists, and whether that will make a difference in terms of quality at primary care, but also understanding a lot more what's happening to people who are waiting in primary care. So we were quite pleased to get that report. We also sort of agreed that there's need to continue to engage with the clinical reference groups on that issue, as well as working on the data and collaborative approach in terms of data sharing and best practice. We looked at transfers of care. but that was specific to the northeast locality, and we're quite pleased with what's going on in that space and what they've done to sort of make sure that when patients are transferred from acute hospitals to nursing homes, there's good quality of material that they are transferred with. Although we sort of did think that actually it would be good to see that piece of work again replicated in the rest of the localities, but it was really pleasing to see the attention that the North East is looking at in terms of transfers of care. We looked at vaccines, and again we are assured that the arrangements around vaccines within Devon are quite satisfactory, but moving forward we did look at, or we said we'd probably also need to look at monitoring the data a bit more to sort of see if there's going to be any issues to do with access to vaccine or health inequalities in that space, noting that we're going to take responsibility for vaccines from April 26, and then thinking about whether that comes with any risks, financial in particular, to taking on that piece of work from April 26. We looked at the quality report, which you just heard from Penny, so I won't add in any more to that. We had the system quality group report. Again, sort of quite pleased with how we're getting to grips with issues around quality between the committee, the SQG, as well as to region, and that's sort of where we need to be in terms of process and being assured that we're looking at quality in the right way. We looked at EQIA as well, and I think we did look at EQIA at board last year at some point, and we're pleased as well with how that is progressing. GP collective action, again, we looked at that, which we've just seen in the other paper here. And I think that the issue is just to sort of highlight the risk of what's happening around collective action, and that's what we've just discussed, as well as the EQIA, which I think will come back to board when it's ready. Thank you.
Thanks very much, Tandy. So any questions for Penny or Tandy? Judy?
I'm sorry, I will try and be very quick, and I don't need answers now. Maybe people could go away. I was concerned about the lack of use of the waiting well service. This was set up at a time when we were really worried about people who were on waiting lists and what was happening to their clinical safety while they were waiting, and also because they were often being told by junior staff in the trusts to ring the GP, and so it came up through the primary care work. And it seems like the Waiting Well initiative that we did fund and did set up isn't being fully used, and yet there is a real risk to people's well-being and safety whilst they're waiting. So perhaps it could come up, the committee could pick it up or bring it up at the next meeting.
Yeah, and I think we might bring it up again at the autism and children waiting as well. That's a relevant issue there.
Okay, thanks, Judy. Any other questions for Penny or Tandy? In that case, then, on Penny's report, there are two actions. One, the first is that the board should agree the overall assurance level in relation to the quality position of One Devon integrated care system as satisfactory. Is the board happy to agree an assurance level as satisfactory? And secondly, Penny's asking us to take satisfactory assurance that adequate plans are in place to mitigate and improve quality risks. Is the board happy to take satisfactory assurance on that point? Thank you. And on Tandy's chair report for the Quality and Patient Experience Committee of the 16th of January, we're asked to take assurance from the report of the chair of the Quality and Patient Experience Committee and note the escalations to the board for information in respect of the emerging risk related to general practice collective action and also the positive development of the ongoing development of the equality impact assessment. Is the board happy to support those recommendations?
And just to add, I think this was sort of missed out, sort of to just note potential risk on the vaccines take up and if there's any financial risk attached to that.
Thanks, Tandy, for flagging up the vaccines issue as well. Thank you. Right, in that case, we will move on to the next items. And just as we've just done on the quality reporting, I'm going to suggest that we take the performance and finance reports at 5.3, 5.4 and 5.4, that we take them together, as all of these reports were considered at the Finance and Performance Committee in January. And then we'll take questions to Libby, Kirsty and Martin after we've done the three reports. So first of all, let's look at the annual Devon Annual Plan Delivery Assurance paper. Over to you, Libby, please.
Thank you, Chair. So I'll take this report as read. As you said, this report sets out the December report, oversight and assurance for the delivery of the objectives against the annual plan. The report was reviewed by the Devon Executive at the beginning of January and through the Patient Experience and Finance Performance Committee. There were a number of areas for the next report that will go into the January report, which will be a new section for objectives that have previously been removed to ensure that we cover those through into next year's annual planning arrangements. So within the report, you've got details by exception or for those areas that have either limited or partial assurance. And just to pick out some of the key headlines within the report, so we have of the now 128 objectives, we have 69% which are fully assured, and that's an increase from 67% in November. 29% which are partially assured, which again is an increase from 29% in November. And limited assurance has decreased from 1% to 2% in terms of limited assurance. Within the paper, you've got full detail of the directorate dashboards, and this is worked through in detail through delivery meetings with each of the chief officers and their directorates. And just for assurance that those with limited assurance which are proposed within this report to be deferred to next year's plan will be built into the work that we're doing in building the 25-26 planning process. Happy to take any questions on that, Chair.
Thanks, Libby, but let's just move to the finance reports and then we'll come back to questions as a whole. So over to you, Kirsty.
Thank you, Chair. For expediency, I'll probably take the two finance reports together because they're all wrapped up into the system report, and I know there's been a bit of debate around that as part of the full report anyway. But basically, we highlighted some risks back in about month 6, which we felt were going to crystallise in the Torbay position and the UHP position. And then in month 8, we formally managed that risk as a system, which meant two of the organisations, the ICB and RDUH, improving their surplus position in order to allow the other two to deteriorate, but to maintain the position as a whole for the system. So that's now actioned and covered in this report here. Main areas to highlight are the efficiencies, whilst we're on track in year or ahead in year, slightly off track for the forecast outturn, but the main area of concern is that we're not delivering at the recurrent rate that we need to protect our underlying position going forward. So that's something that we need to address through the 25-26 planning round. The risk overall has reduced from 29 million in month 7 to 15 million. That's the net unmitigated risk for the system, which at this time of year is quite a strong position. One thing that's probably worth noting is productivity. In terms of productivity, best in the southwest and way above the national average. So I think as a system we need to recognise that as well. I won't go through the detail of capital because we went through the detail of the reports at the Finance and Performance Committee, so happy to take questions or hand on to Martin.
Thanks, Kirsty. So as we've just alluded to, these reports, the finance reports and the annual plan delivery assurance reports were considered in detail at the January Finance and Performance Committee. So I'm going to invite Martin to ask him whether or not there's any points from those meetings that you wish to flag up to the board before we open it up for questions.
Thanks, Kevin. Yeah, we've probably covered most of them, but picking up the two things separately, on the annual plan paper, we did sort of ask if any objectives that have been removed could actually be kept in so we could track them rather than just sort of drop them off completely. But most of the discussion actually was looking forward on how we can improve this or enhance it going into next year, which was particularly around, which are the key objectives, in terms of either, importance to the organisational delivery or, utilising the greatest level of resources. So some way of either reducing the number or at least highlighting the key ones going into next year would be useful. But very happy to sort of accept the level of assurances given on this year's plan, and lots of hard work noted, so good on that. On the finance one, again, most things have already been alluded to. Happy to, having gone through it in detail on behalf of the board, approve and support the levels of assurance given. I think the two things that we noted, which have already been alluded to slightly actually, were, where we have used reserves to manoeuvre the position this year to continue to be planned to be break even. There's some question about what's the downside of that. Have we taken money away that we could have been spending on something else, which was mentioned, I think, by Judy earlier on. And also the issue around where we've got good delivery on the CIP, but more of it non-recurrent than we had planned. What's the impact going into next year? And again, looking forwards, we haven't got the plan for next year yet, other than the sort of medium-term financial plan that we had earlier. But looking forward to getting that soon, now that the national planning guidance is coming out, so we can understand exactly where we are moving into next year. But overall, some fantastic delivery, really.
Thanks, Martin. Thanks for the work that your committee does on this. There is a lot of detail in the annual plan assurance report, and so I know that the executive committee also goes through this in detail. So I just want to ask Steve, is there anything you want to add specifically relating to that report?
Just to confirm that in that review, the exec committee did take its own assurance from all of the delivery. I think just to build on your point, Chair, and looking into next year, we knew there were too many objectives. This was partly about how we get all of these things on track and made sure that we had grip around them. But for next year, the exec team has been really clear. We want far fewer higher level objectives that the board can then engage with and ensure that we are pushing forward on all fronts, but at similar levels. There's just a lot of detail. I think this is partly a legacy issue for this year, but we did take assurance.
Thanks, Steve. So can I open up to questions to either Libby, Kirsty or Martin on these papers? Frank.
It's just to go back to the thing Graham mentioned earlier. I mean, having a 17 million surplus in the ICB is good for the system, but are there things we're not doing that we should be concentrating on?
Kirsty, I'm going to ask you to respond to that, please.
So all of the measures we've taken are non-recurrent, so it won't be affecting our future position and our ability to invest or maintain services going forward. A lot of it has been around balance sheet flexibility, slippage of things in year, and some reserves that we did hold in case there was slippage overall on SIP across the system. So it's stuff that we wouldn't have actively gone to invest in, and we haven't consciously stripped back doing anything that we were going to do. So it's been more of a technical exercise to a large degree.
Thanks, Kirsty. Steve, would you want to add to that?
Absolutely agree with Kirsty. I guess the other thing we ought to acknowledge, though, which is probably behind your question, is that there is an opportunity cost to doing it in this way. And had we had that non-recurrent flexibility, we could have done other things with it. The challenge into next year and beyond is how do we do that? Because at the moment, in reality, we know a lot of our money is a lot of the way in which we are spending our money as a system is having to go into the consequences. You talked about failure demand earlier, of not having done the things that arguably we could do with this money. We're not overnight going to be able to make that jump from one to the other, partly because of the lead times on some of those things, seeing cause and effect. But we've got to, from 25-26, really be strongly signalling that we're moving further upstream, whether that's into community and primary care or ultimately into prevention and population health. Because without that, we will continue this sort of vicious circle. So I kind of acknowledge the point, and Kirsty's right, it's been non-recurrent stuff for this year, but we do need to recognise there is an opportunity cost here that we need to stop spending.
Thanks, Steve. So I've got Judy and then I've got Phil. So over to you first, Judy, please.
Okay, 2 points. Building on the comments about using reserves and entirely understanding, because I had the chance at Finance Committee for this to be explained, that it wasn't necessarily taking money away from other things. But the really important point is it means we haven't made the recurrent savings in the cost improvements, in the running costs, in areas that we plan to. So it's both sides of the coin, and let's have a real focus on that when we talk about the annual plan next year. In terms of agreeing assurance on the annual plan as we have it at the moment, which has been a brilliant piece of work. And I've been so impressed with the way that we now have all these objectives. I'd be very happy to take assurance on individual objectives. At the moment, I don't think it is appropriately analysed per directorate. So some directorates come up as fully assured, some come up as partially assured, and those are not measuring like for like. So if we could exclude the directorate assurance levels and stick with the objective assurance levels, I would be comfortable. I have explained this in advance in writing. So I don't know if Steve is happy that we, or you, Kevin, are happy that we remove that.
Thanks for the point, Judy. Steve, do you want to give us a way forward on this?
Yeah, very, very happy to support that. I think, again, partly a sort of a legacy and an accident of history. How these have landed this year isn't always either commensurate to the work of all of the individual directorates, or indeed, as you sort of allude to, the objectives themselves. Some of them are very low level and some of them are very high level, so there isn't an equality across them. You never get that right, but we're going to be better at that next year going forward. So we do need to give a sense. In the end, executives will be responsible for their planning objectives. So as we move into 25-26, the first step is ensuring that they are well balanced across the directorates, that they are of similar complexity and ambition, which is art rather than science. But then as a board, particularly for the independent members around the board, that you can then hold us as a team to account for delivery, because even in that split, one director will be relying on a number of other directors in order to achieve their objectives. It's who's the sort of prime holder of it. But as a team, we will be working on it together, so we need to look at it as a team.
And if we could add resourcing to that too, which we've been talking about.
Okay, thanks. While I come to Phil, Judy, I wonder if you could just give some thought to how you'd like that action recommendation to read, and then I'll come back to you if you're okay with me giving you that task, given that you raised the point. But I'll bring Phil in now, please. Thank you.
Thank you. One for you, Kirsty, if that's okay. It's what's drawn my attention is the service line summary and the executive summary part of the finance report, and the line that says mental health as a forecast overspend of 2 million on it. I just want to check my understanding is that that's driven by the right to choose adult neurodiversity assessments, which is spent with non-NHS providers. Yeah. Yeah.
Sorry, it's outside of the.
Yeah.
Yeah, that is predominantly what it is.
Okay.
Yeah.
Thank you.
Thanks for that clarification on that. Any other questions for Libby, Martin or Kirsty?
Yeah.
Oh, sorry, Graham, I didn't see you come in, Graham.
Sorry, I do think about things other than productivity, but can I just turn to the productivity bit, which is sort of down the back end of the report, and sort of three things really. One is, as I think Sam already alluded to, the diversity within an average, and this is a very, very high level number. So I don't know quite how robust it is. Assuming it is robust, are we getting the recognition as a system that we should do? Because that is quite startling of us versus an England benchmark. But assuming that those two are indeed robust, the third thing I'd request is that when we're starting to build our operating plan, and I know today's a lot of announcements about the guidelines, I think it's quite a useful metric, possibly unpacked to some degree. I mean, I spent years in GE healthcare where it used to focus very much on productivity, and it is a good measure of the plausibility of your plan about what's achievable. So I'd quite like to see that in the plan about what we're expected to achieve as a metric, please. So that's a request for the future.
Thanks, Graham, and I'll bring Kirsty in on that. Is the productivity metric robust, and how does that look compared to the rest of the country? Are we making enough of the progress on that?
So it is robust. It is nationally calculated, so it's not our own view on the world. It is against the national position and calculated and provided to us. It's interesting what you say about going forward Graham, because there's in the 25-26 planning guidance, there's an expectation of productivity as a minimum of about 4 or 5% across the board. We've also been sent productivity information packs which highlight all of the areas that we can still go at, and part of our planning submission is we will need to be able to demonstrate that we've addressed all of those issues where it shows that we can go further on productivity. So it is starting to be much more of a key metric in measuring how we deliver.
Thanks, Kirsty. I'll just bring Steve in on this point as well, please.
Yeah, I think Kirsty's mostly made my point. Thank you, Kirsty. It was just we are trying to ensure that we make this argument with the regional team and beyond. I think people do acknowledge the significant improvement in productivity. I don't think it was formally part of our exit criteria, but it is one of the things that we will put in as an argument for the fact that the system has improved. I think also looking into next year, 25-26, and given that what I know will be some significant challenges, as Kirsty said, we need to demonstrate whatever our answer is, if you like, that we are really pushing on productivity again into next year, that we are doing some of the big system moves that we described in our Transforming Devon programme around things like corporate services and pathology and so on. So we can demonstrate up the line whatever the challenge might be, actually this system is becoming more and more productive, is doing the back office and the clinical support service strategic changes it needs to, and is then trying to drive forward with other areas. That is the case we need to put together as convincingly as possible for next year.
Thanks, Steve. And Phil, please.
Yeah, just on this one, actually, because my ears really pricked up when you sort of in your introductory comments talked about that really good productivity. And actually, when I sort of look at it again, it's brilliant relative improvement, isn't it? But it depends where you start. And that's the bit that sort of doesn't quite come out. So if you start a long way back, it's still brilliant, isn't it? But it doesn't mean that all of a sudden we're top quartile in absolute terms. So that's the bit that's missing, I think.
Thanks, Phil. That's helpful. Any other questions on these papers? If not, I shall move to the recommendations. So on the Annual Plan Assurance Report, we're asked to agree the assurance ratings relating to the delivery of NHS Devon's 24-25 Annual Plan objectives. In conversation with Judy here, I think we're suggesting we don't change that recommendation, but we just note in the minutes that the ratings that are applied to the directorates may not reflect the level of resource to those directorates and the relative challenge to those directorates. So if we're happy to agree the assurance ratings, but with that rider around the directorates, would the board be happy to do so? And then we're asked to agree the proposed amendments to the NHS Devon 24-25 Annual Plan. Is the board content to agree that? On the finance reports, we're asked to agree an overall assurance level relating to the financial position of NHS Devon of satisfactory. Is the board happy to agree an assurance level of satisfactory relating to the NHS Devon financial position? And are we happy to agree an overall assurance level relating to the financial position of the integrated care system of satisfactory, and note the system reforecast that took place in month 8? And in terms of the Chair's report from Martin, relating to the Finance and Performance Committee meetings of the 11th of December and the 17th of January, we're asked to take assurance from the reports of the Chair, and also to note the escalations for information contained in the report of the meeting held on the 17th of January in respect to the ongoing challenges in urgent and emergency care, and the understanding of non-recurrent and recurrent shifts resulting from operational efficiencies and delayed expenditures, and the use of financial reserves within the system. Are we happy to take that assurance and note those points from the report? Thank you very much. We'll now move on to item 5.6, which is the 25-26 Planning and Transformation paper, and I shall ask Libby if you would like to take us into that paper. Thanks, Libby.
Thank you, Chair. So the paper that the board have today is an overview of the work that we're doing to align the elements of planning for 25-26. So bringing together the work around the joint forward plan, the operational plan, the Transforming Devon programme, and then looking forward in terms of our ICB annual plan. So part of the work we're doing at the moment is to be really clear about the alignment of the elements of the planning for 25-26. As has already been said, obviously today is a key day in terms of the planning guidance being available. So we have been working with the providers in terms of initial submissions around the operational plan pending the release of the planning guidance today. And we are working to key deadlines around that over the coming weeks. In terms of the previous paper around the 24-25 plan, we're also being really clear about the transition from 24 to 25, including those areas of the 24-25 objectives that we need to make sure come through into the 25-26 planning. And one of the key areas of work that we're doing is looking at a different approach to the planning objectives for 24-25, in that we look at cross-cutting planning objectives led by each of the chief officers, where we're then really clear in terms of translating that into delivery and enabling plans across all of the directorates, and aligning that to the roadmap for the development of the ICB strategy as well. So happy to take any comments, Chair, but just conscious that this is very much work under development at the moment.
Thanks, Libby. It does very much feel that we're very much ahead of where we were this time last year in terms of thinking for the coming financial year. But are there any questions for Libby on the paper? Judy, please.
I'm sorry. This is really good and well done to everyone. I would like to just suggest that in para 28, which is on page 233, under the financial plan, we actually add an objective about ensuring the cost improvements are recurring as opposed to non-recurring. So it becomes an absolute focus in the discussions, if that were appropriate.
Are we happy to accept that as a proposal, Libby? Steve?
Just a slight tweak, because it might be that not all of the CIPs are recurrent, but we will be clear about the degree of recurrence. But there's normally a sort of percentage that we aim for, which from memory is about 70%. We would expect at least that as a minimum in order to make progress on the underlying position. Yeah.
Sam, and then Frank.
So inevitably, things move on, don't they? So some of the metrics in para 28 have evolved, but that's absolutely fine. We just have to try and keep up with. The one that it struck me was missing in the UEC subsection there was certainly from the acute provider perspective, we need to be really clear about no criteria to reside levels for next year, because otherwise it's impossible for us to plan. So we need a discussion up front with system partners about what we're going to commission and what level we're all committed to.
Thanks, Sam. Steve?
Yeah, I agree, Sam, and I think we need to be really clear, because every part of our system, as you know, is in a slightly different position, and I think also for Tracy, there's a particular issue in Plymouth that we'll need to agree an NCTR there, which is commensurate with the plans. I think the other one, just as you're right, Sam, this morning we had some updates, but of course there's going to be a really clear focus, if I heard it right this morning, on 12-hour waits in ED, so we'll need to put that in as well.
Thank you. And Frank?
It's just one of emphasis, really. I mean, I think the transformation plan is great, but if we align it with one of the three big changes, it's about the whole plan for the patient, so the whole pathway. I just don't quite get there's enough community perspective in any transformation at this point in time if we're going to end up in a different place.
Thanks, Frank. There's a lot more work to be done on this over the next 6 weeks or so. Isn't there? So the points that have been made in the meeting around some clarity around the ambition in terms of recurrent CIPs, clarity around no criteria to reside focus, and also aligning the plan to the 3 shifts and the DARS report and the 10-year plan will be work which I think is going to be going on over the next 4 weeks or so before we bring this back, hopefully to the March board meeting. Libya, is there anything you want to say in conclusion on this before we move to your recommendations?
No, thank you, Chair. Nothing further.
Okay, so if we move to the recommendations, we're asked to take satisfactory assurance from the ongoing integrated approach to planning, and we're asked to take satisfactory assurance from progress in establishing the architecture for the Transforming Devon programme. Are we happy to take those 2 assurances? Thank you. And then we're asked to note the indicative timelines for operational planning, as well as the assumptions and ambitions shaping the One Devon Integrated Care Systems operational planning in 25-26 and risk inherent within the assumptions. And we're asked to endorse the response and shift of emphasis in development of the NHS Devon annual plan. Are we happy with those 2 points? Thank you very much, and thank you for all the work on it, Libby, and we look forward to a further conversation on this at the March board meeting. We now move to item 5.7, which is an update on the Children and Young People Services recovery focused on autism, and I'm going to invite Penny to take us into this paper. Thanks, Penny.
Thank you, Chair. And one of the things I do want to say, I really appreciate the time that we need to spend on this really important area. I do, however, recognise the need to be concise for the purpose of the board. So any questions arising that are beyond the scope of today, I can obviously take forward. So briefly then, in terms of background, so Devon is not uncommon in experiencing extreme increased demand for autism and wider neurodiversity assessment for children, young people, and for adults, but that's a different paper. One of the key points I want the board to recognise that in conjunction with driving down waiting lists, it's really important that we address the early help offer, that there is an earlier intervention, and we need to do both. So the autism pathway is delivered in a complex system in Devon, and it is delivered by Live Well South West and also Children Family Health Devon in conjunction with other partners. And of course this paper comes after the July report to board outlining the current regulatory position around SEND and also the current position performance-wise. And there was a very clear commitment by our board at that point in time to drive down those children waiting over 52 weeks waits, recognising the adverse impact that this can have on children's development. And it's not only their health, it's about their social and education developmental needs. So since that time, a number of key actions have been taken to date, but you will see in the summary of my report, I'm recommending limited assurance, not so much on the actions taken, but the impact of the actions taken. So you'll see within the main body of the report that there have been over 1,100 assessments have been completed between August and December, but the rate of demand is exceeding our ability to respond. So we need to do something differently. And just this week, in fact, I've been working with Torbay Council and Devon County Council on really looking at different therapeutic models. And, you know, what we need to do is stop pathologising children. We need to wrap the care around them in their education, at a really early stage. And that's been subject to, that appears in our future annual plan and has been subject to investment, business cases going through our processes. One of the things that is constraining us is the right to choose element, and we are recognising that families understandably are responding by going to individual private providers. and that is actually causing a real issue with our own staffing numbers. There's a drain of our workforce into a private situation, or private provider market, and that's not only big, large independent sector, that's individual practitioners. So we're constrained by workforce, and therefore, once again, we need to be doing something differently. And we've been linking in with various colleges to look at what could a more multidisciplinary approach look like for those children who, when clinically triaged, could be dealt with or responded to in a different way. The other constraint I've alluded to is the availability of workforce, and one of the things that we're working through at the moment is the different employment models that are evident both in Devon but also wider, so we're actively learning. One area that I recommend the board to understand and support is the fact that we are aligning this performance metric to the One Devon oversight arrangements, and it's been really good to work with John Finn. So the One Devon elective recovery programme will incorporate this metric, and I think that does a great thing. Actually, it puts children, it's parity for children in our focus and in our line of sight and our controls. And then also simultaneously we've been working with, for example, Phil, I've been working with you from a Children Family Health Devon perspective, and I have to say the executive leadership focus that's coming to bear is making a real difference. So I'll pause there because it's important to take questions, but I hope the report provides sufficient information, and also to note that progress will be monitored through the Finance and Performance Committee, and also from a quality impact through the QPEC arrangements.
Thank you very much, Penny, for a really informative report and for your presentation of it there. I've got Judy and then Tandy and then Lincoln. Judy, please.
Thank you very much. As it happens, Penny's answered all my questions in her presentation, so that was great. Thank you. I just wanted to really commend Penny for really getting grip on this issue. We've been trying to do this for a long, long time, and as I read this report, I felt, at last it's beginning to get, and I hear your thanks to colleagues for supporting you on that, but this has to be mainstream for this organisation. Thank you, and thank you, Penny.
Thank you very much, Judy. So I've got Tandy, and then I'll bring in Lincoln, Graham, and then John. So Tandy, please.
Yeah, so echoing Judy as well about how pleasing it is to see this finally getting to this space. From my point of view, we're here, but actually, I think whilst we're sort of getting really concerned about the size and the numbers, I do think that probably autism is something that we need to see slightly differently. The new way of thinking that you talked about. Normally, you get the diagnosis, then you get treated. But I think that this model is just not working for these children. And I think that some of the treatments these children need are treatments that are good for any and every child, whether they've got autism or not. So I think that moving forward, we probably need to think about what are the parts of what these children are struggling with that we can start delivering, whatever the numbers are doing. Because I think what's happening is parents are waiting 100 weeks, and there's that build up to waiting and waiting and waiting, only to be told that your child has got that which you thought they had anyway. And then at that point, you start organising the support. But there's things like speech therapy, behaviour, support for the parents and all that. I mean, ADHD, yes, because sometimes there's drugs and things involved. You can't really give that to children without diagnosis. But I think there's some stuff that we can do and give children before they get to the diagnosis stuff. So I think this probably should be part of the thinking differently about how we treat these children, so we don't have children wasting 2 years. And that's a long time in a child's life to wait to get something as basic as speech therapy, for example.
Thanks, Tandy. Is there anything you want to respond to on that, Penny, before I bring in Lincoln?
Tandy's comments is congruent with the feedback we've had from families and children and young people, and certainly is part of our design principles, and I think we really do need to run both of these pieces in tandem. So we, for example, are under an accelerated improvement plan from Devon County Council as part of the SEND regulations. That's wholly focused on reducing the waiting list. We need, and we are, I'm working with Julian Worcester and we're working with Region to try and influence the fact that we'd like to be measured on the early help offer as well. So again, it's about making sure that the oversight is conducive to doing the right thing.
Yeah, so I think there's something about...
Tandy, could you put your microphone on, please? Thank you.
Oh, sorry. The second point I would like us to think about as well is that these children aren't going to be children forever. At some point, they'll be 18, 19, 20. And because there's a large cohort coming through, I think we need to think very carefully, future-wise, in terms of at that point when they're becoming 18, 19, 20, the focus on adults with autism is a lot less than there is on children. And I think that should be part of, again, of forward thinking.
Thanks a lot, Tandy. Lincoln, please.
Good. Tandy has said quite a lot of what I wanted to say, and it reflects what I said earlier, which was some generic principles around working in this space. Early help, what we call a graduated response as well, those elements are beginning to be established. Again, the issue is trust and confidence. So clearly, if we are not seen to be making those impacts, schools, parents, carers then feel they have to accelerate, they have to escalate the situation. The question I wanted to focus on is the whole one about doing things radically different. And the early help also works for those who will have a diagnosis, those who are fortunate to get to the end of the waiting list. All of those things that we're putting in place are still relevant for them because it's a so what of a diagnosis, a label, yeah? But it's how do we move the system to do things radically different? Because I still hear too much about the way we manage this is to have more specialists, more, and I'm thinking, no, we have to begin to understand there is something different. These are people who view the world in a different way, yeah? And we're still using a medicalized approach to something that is different, yeah? So it's a multidisciplinary, and it's how do we get the professional buy-in, how do we influence current specialists, value what they do, but also the work of how do they open up to work with other disciplines, whether those are in health or indeed in the voluntary sector or in local government, to really do something radically different, because more of the same is not going to cut it.
Thanks, Lincoln. Is there anything you'd want to respond to on that, Penny?
So yesterday, Lincoln and I were working together with Children Family Health Devon, and we were talking about how do we help the person with the significant relationship closest to the person have the necessary skills. How do we have an outreach model and work through others in a dispersed way? So part of that will be about professionals relinquishing their clinical control, but actually I heard a real appetite in the room yesterday to, yes, let's press into that. So, and I really like Tandy's point around what are those others measures of success, and I think that's something I'm going to take back.
Okay, thanks for that. And Graham, please.
Thank you. So yes, I'm interested in geography and variation. So 3 organisations are cited here, and I'm not quite sure I know exactly how it divides geographically, but it was very striking to me that CHFD has by far the largest numbers and the longest wait, through to Live Well, a much smaller number and a smaller weight. So do we understand why that variation occurs? And Penny, what's your confidence level that we are indeed sharing the best we can across the geography, please?
Thank you. If you don't mind, Graham, I'd like to invite Phil to respond to that, but largely because we've had such good conversation recently, and you may be able to share some insights before I come back.
Okay.
Thanks, Penny. I think where I'd just respond at this point, because there is a lot of work ongoing, is that the size of the geography is significantly different between the two providers, and therefore the referrals will be too. So that will be a scalable sort of explanation. But there are absolutely conversations happening at the moment, understanding what one provider does that works really well that the other should think about as well. So that's all part of the conversations that are happening at the moment.
Yeah. So and it's not all one way actually. What we're building is rapidly building a culture of sharing and trust. I think it's really interesting employment model in Live Well, for example. But I also recognise Children Family Health Devon have a different referral pathway. There's a lot to sort out, and I think what we've been brave enough to do since July is really understand the strengths and where we need to further improve.
I think there's a note in there as well that the Live Well ones from a mental health perspective as well as in the specific patients. Yeah, so that could also explain that difference, I think.
Thanks. While you've got the mic, Phil, you had another point I think that you wanted to make, so I'll bring you in now.
Yeah, I just really wanted to endorse the conversation that's been had in a roundabout way about needing to really think about the sort of biopsychosocial model here and not overly medicalising, and really understanding why people want and need a diagnosis as well. Because the wrong thing, I think, in this instance to do would be to layer so much resource into a specialist pathway that you reduce and resolve that problem, and then all of a sudden the needs that people need once they've been diagnosed can't be resourced because we've built too strong a specialist diagnosis pathway. So I think it's complex but resolvable. Yeah.
Thanks, Phil. So I've got John, Sam, and then Judy. So over to you first, John.
Thank you, Chair. It's just, I think it's important just to bring in the components of One Devon into this. Penny asked me at the beginning of the year to be part of this, and I think it plays really well to the board's expectation that for our most complex issues, we're looking across all our directorates. But no, Sam is even proof basically of a methodology that we have developed in Devon across One Devon elective, both at organisation and individual level, which is basically a culture of recovery and continuous improvement, actually, which has really worked for our patients in Devon. But what does that mean? And that's a big statement, actually. But our use of the correct data, understanding data, bringing in our clinicians, our professionals, our service users, and having the right and most talented managers on our most complex issues is really important to have that transform pathway agreed. And we've done it, and this is the methodology we'll bring in here. There are other components. Really, really good contract management. We don't have a single PTA for this across the system. Actually, in our most challenged areas, actually, that's what we've done. That brings the real benefits of mutual aid to the task, actually. So not just Live Well, but what mutual aid can the independent sector provide? So I said, we'll work really hand in glove with this, with Penny's team, basically, but I have a real ambition in terms of what we can achieve over the coming months in this.
Thanks, John. And Sam, please.
Lincoln and John have said most of what I was going to say, Chair. I mean, it's great we're having the conversation. Sitting here, 71 weeks wait if you're a child is just unacceptable, isn't it? So we've got to do something about it. I think we've massively over-medicalised it, and we need to look at where we have made improvements in other aspects of care. On, as John says, on the elective side, what we've basically done is torn up the pathway and started again. And we're going to have, I think we just need to get on and have that conversation.
Thank you, Sam. And Judy?
I just wanted to reinforce the workforce side of this, and Piers, this is an absolute classic of where the workforce team should be working with the clinical team and looking at new roles. If you look at other areas in the NHS where we've had massive increases in demand, associate practitioner roles who focus on specific things but can be given generic activities, it takes years to train the clinicians that are actually leading on this work at the moment. And what we've done in the last few years is simply give money to appoint a few more of them, who we then lose almost immediately into the private sector because of their opportunities for flexibility and different funding. So, and because of the demand, as you say. So this is a real example of where some intensive support on new roles and different ways of working would be very helpful.
Thanks, Judy. Frank, please. Yeah.
I'd just like to agree about the biopsychosocial model for these children. I go into a welfare meeting in Devon High School every fortnight. Yesterday I read through 18 sets of notes. Quite a few of them are neurodiverse, and that was and what you see is a massive impact not only on them, but on their school attendance, their families, their parents, their siblings, and it's really, really important. I absolutely agree that we've got to deal with the sort of behaviours and things before we get the diagnosis, but that's a solution to a problem that shouldn't exist. It shouldn't take 2 years to see somebody, and there must be worldwide other ways of making this sort of diagnosis. I'm sure that there must be AI ways of assessing and analysing, and we really do need to think outside our experience at this point.
Thanks, Frank. And Penny, I don't know if there's any response you want to make to that, or any closing comments that you'd like to make before we move to the recommendations.
First of all, to thank everybody for their comment and the backing of around this work. The complexity should not defeat us. We will remain tenacious in this area. The step change that has happened, thanks to John Finn and making sure that this actually is incorporated in our best control mechanisms and improvement mechanisms. So I do want to formally record my thanks to John and the broader team. But that's to conclude.
Thanks very much, and it's been good to spend this much time on this paper in the meeting, and really good to see the progress from where we were a year ago, and really good to hear the confirmation from the board of the priority that we want to attach to the children and young people's services now. So if we move to the recommendations, what we recommended here is that we take limited assurance from the actions taken to date, and as Penny said earlier, this is relating to the impact of the actions yet to impact, which is why we're rating it as a limited assurance rather than satisfactory. Is everybody happy to approve that limited assurance rating on this? And secondly, we're asked to know that further information about progress will be presented to the Finance and Performance and the Quality and Patient Experience Committees as appropriate. And Penny, when would you see the board having another conversation like this? What timing would you suggest for that, to bring it back here?
Because we've got those other mechanisms in place, and those are established in terms of the One Devon elective board arrangements, my suggestion is no sooner than 6 months. This will take really consolidated effort, and I think it would be premature before that.
Thanks then, Penny. So we'll note that it will be overseen by those two board subcommittees, and we'll look to schedule another conversation on this at a full board meeting in around 6 months' time. Thank you very much. We now move to item 5.8, which is the board assurance framework. Philippa, can I ask you to introduce this paper, please?
Yes, thank you. In the spirit of brevity, I won't go into the detail of the paper because I assume that everyone's read it. I think there are two key points that I wanted to pull out which are not addressed in the paper. One is we're obviously reaching towards the end of the financial year now, and we're beginning to think about what our BAF should be looking like for 25-26, and we'll be tying in very closely with the work that Libby has described around the annual plan and operating plan. And the strategic objectives that we're pulling through there. So I think we'll probably we'll be seeing quite a different BAF for 25-26. We'll have an opportunity to discuss that and risk appetite at the board development session next month. So I wanted to flag that is work that's beginning to start now. In terms of the current year's BAF, I think probably the key place to direct people's attention is the table just above paragraph 17. I think what's quite striking from that table is that we haven't seen a lot of movement in the risk ratings. and I know this was a challenge that the chair of our audit committee gave us at the last board meeting, and it was a challenge that we took to our executive when we discussed this report before we submitted it for the board. And broadly speaking, we did really challenge ourselves as to whether we thought we needed to be looking at different risk ratings for these risks, particularly in light of the experiences that we've had over winter and the changing financial environment that we've seen across the system. But we really did feel that actually the context was shifting in such a way that actually it wouldn't be fair to change the rating of the risk, because our response to the changing context that we're operating within means that actually we've been able to manage the risk. And in other years, we probably would have seen risk ratings going up, and we haven't seen that this year. So I think that little bit of additional context is probably helpful, but that's probably it from me.
Thank you, Philippa. Any questions for Philippa, or observations on the board assurance framework? Okay, so we're asked to approve the content of the latest iteration of the 24-25 BAF risks to achieving the strategic objectives of NHS Devon. Is the board happy to approve the content? Thank you, and let's note that work on the 25-26 BAF is commencing, and note that we will start to have a board consideration of this at a board development session at the end of February. Thanks, Philippa. We move on now to the section on partnership working, and I'd like to invite Tracy Lee to give us the update from Cornwall and Isles of Scilly. Thanks, Tracy.
Oh, there we go. Thank you, Chair. I'm not going to probably focus particularly on what's in the report, because I'm sure you will have all read it, but just to point out, in fact, it's probably common to most agenda items today that we've got very similar issues in Cornwall. We had a critical incident at about the same time as you after Christmas. I think what was stark this year is how quickly we were able to recover from it on the basis of some of the community infrastructure we've put in place over the year, and which we will hardwire and sustain through our plan for next year. And one of the things we've talked about quite a lot today is primary care, and I think the primary care hubs that we've put in place this year are giving us additional capacity to be able to flex according to demand, and we did put in place an additional 2,000 additional GP appointments over that period to help us recover more quickly. Probably just a couple of other things to add. We are still reporting that we will achieve financial balance at the end of this year. That will be the 4th year in a row. But I just wanted to reassure you that it doesn't make it any less challenging when we're looking at next year's budget. And I think particularly because we are making recurrent some of the investment we've put into community infrastructure this year, and that has an impact particularly on our acute trusts and the funding that's available there. There are 4 schemes that we are particularly focused on, our system reform schemes for next year. The first is frailty, and we know that they are probably our biggest cohort of patients who have avoidable emergency admissions, and they are key to decongesting the hospital and maintaining people in their own homes. Similarly, end-of-life care patients, so we are developing 24/7 community palliative care services so we can wrap support around people rather than them going into the hospital in the very last days of their lives. Discharge to assess, and that's particularly focusing in on and linked to the frailty system reform work. And lastly, integrated neighbourhood teams. So we are putting in place our first phase of integrated neighbourhood teams in areas of highest demand. And we've had an expression of interest process over the last couple of weeks, and have been overwhelmed with support from our primary care hubs who are keen to be part of that first round. And we are investing in them from next year, and in particular thinking about which acute services they can bring out into the communities with some consultant input. So I think that's probably our most transformative area of work that we'll be taking forward next year.
Thanks very much, Tracy. Are there any questions for Tracy? I've got Sam first, please.
Thanks, Tracy. Same point I made earlier. We need to agree, particularly for West and North Devon, with Cornwall, the level of no criteria to reside patients we're going to have in the hospitals for 25-26. So it'd be really helpful to pick that up outside of the meeting.
Thanks, Sam. Any other questions for Tracy? In that case, let's note the report from the Cornwall and Isles of Scilly ICB. We next move on to the committee chair reports, and the first one is the report from the Audit and Risk Committee of the 6th of January. And I'll invite Graham to present this report to us. Thanks, Graham.
Thank you very much indeed. Yes, so the last meeting on the 6th had a private session which actually we've postponed, and that will be on Monday, this coming Monday. Private in the sense that it involves some individuals and some specific organisations, but the underlying issue is already in the public domain. It goes back a while to international nurse recruitment as the sort of the core of it, but it sort of ended up looking at other aspects around procurement and controls and the like. And an action plan was put in place, and so that private session that got postponed from the 6th to this coming Monday is around monitoring the implementation of the various actions that flowed out of work conducted by both Counterford and ASW. So, in terms of the last meeting, I reported on the chairs network that has started, as I think most people here know, commissioning some internal audit work across the system as a whole. And we actually received the first report formally on the SIP work and the adequacies of plans. I believe that's gone to various providers, boards, audit chairs meetings as well. And I think that was a very promising first system-wide piece of work that was undertaken. I think it helped give us the assurance that overall the SIP plans were well planned and well governed. It did actually also put a small flag up, which I think has grown in terms of TSD. So I think that was a very helpful first piece of system-wide audit work. Two other pieces that we commissioned, one we've actually decided to not undertake, around ambulance handovers. And the reason for that is just the timings versus the winter pressures. That didn't look a very sensible move. Another piece is still going ahead, which is around maternity services. We've got to put a self-assessment in for March around a number of aspects of our maternity services. As I'm sure we're all aware, we have some challenges in maternity services, but if we can demonstrate various things, then actually we do get a rebate on our payment for negligence to NHS resolution. So it is both a financial impact and also, of course, a community people impact. So we will be proceeding with looking at the adequacies of maternity services returns for the end of the year. We've looked at the status of our various policies because we monitor what they are and when they need to be refreshed, etc. There are a few that we will continue to check. Don't fall behind in terms of updates on those policies. In terms of the internal audit programme, we are well on track this year and in a better place actually than we were this time last year. We seen 6 reports coming back. I'm sorry, but inevitably I'm bound to report more on the negative ones than the positive, but due credit for all the positive ones. But the 2 which came back with only limited assurance, I should just flag here, I think. The first one is on emergency prep resilience response, which came out for the ICB as limited. And that was due to deficiencies in some departments, some divisions around the plans, training, and to some degree the adequacy of the resources. Whenever we do see a limited report, we also do ask for a more thorough response. So we looked at the adequacies of the response, and I think we had reasonable assurance that despite having come through as limited, that actions were being taken to address that. In the pack, you'll also see, however, a longer document, which I think is there for noting to the board around EPRR annual assessment for the system as a whole, as opposed to the ICB as an organisation. So this looks at not just the ICB, which has an enhanced role in taking a lead when ICBs were formed, but it also looks at the ambulance service and each provider, etc. And I'm pleased to say that one has come out as satisfactory. So having already heard that it was limited on some aspects within the organisation, in the context of the overall system, I'm pleased to say I think we're reporting being in a good position. The second piece of work that came out as limited, which had already been flagged to me, and I think Penny, you and I had a pre-conversation about this, was around IPP and the section 117 area, and particularly around the governance arrangements of that. And I guess to summarise what the issue is that whilst the ICB commissions this to a number of organisations, I think the number of it was that we'd probably underinvested actually in fulfilling the ICB's part of being on top of performance and commissioning arrangements, with the concern that there could be some gaps of people not being picked up as we are statutorily obliged to do. And therefore we had to strengthen our own governance arrangements. And again, we had a separate paper response to that internal audit findings. And I think we were assured that work was already well in hand to address those deficiencies. Beyond that, we've obviously now hit the 9-month mark, heading towards year end. Internal audit is, as I've already said, well on track. It's a little bit too early to share their and our view of the overall rating for the year, other than to say I think we are in a much better position than we were this time last year, not only in terms of the work, but also in terms of our performance. And obviously we'll have the external audit work starting as well. So at that point I'll stop and open it up to any questions.
Thanks for that very, very thorough report, Graham. Are there any questions for Graham on his report from the Audit and Risk Committee? Frank?
It's one on the EPRR. On page 293, number 12, it says a concern was raised with NHSE regards the deep dive in that the EPRR staff do not have the cybersecurity knowledge or expertise necessary to effectively undertake and confirm and challenge process. Our biggest risk, the more interconnected we get, the biggest risk we have is our computer systems. And I mean, we have no idea what sort of malicious intent people might have. So I think that's quite an important thing for us to focus on.
Philippa.
I think it's a really important point, and thank you, Frank, for noting. I think one of the things that we need to think about from an executive perspective is how we link up the work that we do around the assurance in relation to EPRR and the work that we do around the data security protection toolkit, where we report about our information security work, which would then address that cyber security issue, as well as our information governance work, because I think a number of the issues that were probably raised through this will be picked up through that toolkit, so there's probably a linkage piece there that we need to follow up.
Thanks for Penny.
Mine was on a separate point.
Yes,
yeah. So simply for the benefit of the board to link the various committees of the board reports. So section 117 IPP audit was referred to in the quality report, and the quality impacts are being overseen in that area. And also simply to say the internal audit was instigated by myself as part of my due diligence.
Yeah, thanks for that, Penny. Any other questions for Graham? If not, then can we take assurance from the report of the Chair of the Audit and Risk Committee? Thank you. We take assurance. We need to approve the EPRR Assurance Report 2024. Is the board happy to approve the report? Thank you. We approve it. And finally, we are asked to approve the 4 proposed outcomes for assessment as part of the Data Protection and Security Toolkit, those being A1A board direction, B3D on mobile data, B3E on media equipment sanitation and sanitisation, and E2A managing data subject rights under UK GDPR. Are we happy to approve those 4 proposed outcomes? Thank you very much, and thanks for your report, Graham. We now move to the report from the first meeting of the Population Health Improvement Committee on the 9th of January of this year. And Tandy, thank you for stepping in and being the chair of this new committee while we're awaiting our new non-executive members. Would you like to report back from the committee, please?
Yeah, thank you. Again, starting on a positive, I think it's really pleasing to see that this committee is now up and running, having spent the last 2 years sort of pontificating amongst ourselves that we really need to do something about health inequalities. It's really good to see the committee sort of now starting to get its act together. But for that same reason, obviously it's an emerging committee, and so one of the things that we're looking at is the terms of reference, and to see whether those terms of reference are in line with the objectives, the annual plan, and whether we've got adequate representation on the committee itself. So for that reason, we did make some recommendations in terms of proposing that the terms of reference be amended, and you've just done that in the chair's report, as well as looking at whether somebody else or other people need to sort of contribute to the agenda of the committee. Some of the pieces of work that have moved, or we recommended be moved from the QPEC, the Quality and Patient Experience Committee, include the public engagement, which the reason being that actually the population health will be looking at everything to do with patients that's out in the society, in the community, versus QPEC really is about patients and what's happening at the point of treatment. So public engagement and involvement has moved to the population health, whilst, yeah, I think that's sort of what we agreed on the day and what you just approved today. I think apart from that, I don't think I've got much else to add.
Thank you, Tandy. Are there any questions for Tandy on her report from the Population Health and Improvement Committee?
We didn't take any assurance, obviously, because it was the first committee, and I think it will probably take another 2 or 3 meetings for us to be on the same page as the rest of the other committees, I reckon.
Thanks, Tandy. Phil?
Thanks. Just reflecting on what an important committee it is anyway, but in the context of the thinking we're going to have to do about future care delivery decisions we're going to need to take in a constrained financial environment, I think it's even more important that it's not just you do the quality impact assessment on safety and experience, but also think about the impacts on the different bits of population. So I think it's
so
vital.
The entire agenda around health inequalities will be sat in this committee, and I think that is an area that everybody around the board has agreed that actually we do need to do a lot more around that. All of those issues to do with social determinants of health and who's being affected by how and what their outcomes are really is going to be nested in this committee.
Thanks for that, Phil, and thanks, Tandy. So let's take assurance from the reports of the Chair of the Population Health Improvement Committee, and we note the recommendation that the terms of reference of the committee and that of the Quality and Patient Experience Committee should be amended concerning public engagement, which have been approved under my report earlier in this meeting. Closing items then, we did take a question from a member of the public earlier, but I just also want to note up that Councillor Jan Goffey of Oakhampton Hamlets has submitted some observations around items on today's agenda. She can't be with us at the meeting today, but we are going to respond formally to Councillor Goffey in due course. Is there any other business which members of the board would wish to raise before we close the meeting? Okay, thanks very much. The date of the next board meeting in public will be the 27th of March 2025. Thank you for all of your contributions today, and we'll see you at the next meeting in March. Thank you.